Hi everyone, good morning. A very warm welcome to our UMC Urological webinar, Busting Common Urological Myth. I am Jeffrey Lim, the chairperson for today's event. And this brings me joy to see the incredible response that has led us to the second year of organizing this forum. In a world that is filled with information, it is crucial to differentiate fact from fictions, especially in the realm of urology. Our dedication to delivering accurate knowledge is the driving force behind this webinar. Some housekeeping rule as we embark on this enlightening journey, I implore each of you to actively participate, host questions. Our panel of experts will unravel the misconceptions and share insights that will enrich your understanding of urology. Another housekeeping rule, our QR code for CPD point will be available on the screen at the end of the webinar. Please scan the CPD QR code using your MMA apps. All right, without further delay, I would like to introduce you our Head of Unit, Urological UMMC, Dr. Ahmad Nazran for prologue. Thank you, everyone.
Hello. Assalamualaikum and good morning, everyone. I'm Ahmad Nazwan, Head of Division of Urology for PPUM. So first, I'd like to welcome everyone. As Dr. Jeffrey mentioned, it's the second installment of our virtual urology webinar. So we actually have prepared a wide range of topics, all given by urologists in University Malaya Medical Center, which we hope will help to dispose myth and fact to set the correct facts straight. Okay, I would like to first thank my team. Okay, some who are here and some who are not here. We have worked very hard behind the scenes to make this webinar a success. And also thank you the sponsors which are listed below. Who have helped again to support this continuing webinar. And last but not least, I'd like to thank you, all of you, the GPs who have come for this webinar, because the main thing that is going to make this webinar success is your active participation. Okay, so we welcome Q&A, any queries, any questions, please do put it forth so that we can all learn together. Okay, with that, without wasting any more time, we'd like to officially start this 2023 version of the virtual urology webinar UMMC. Thank you.
All right, thank you. Thank you, Dr. Ahmad Nazran, to officiate our webinar. So now I would like to pass the screen to our moderator for today, Dr. Desmond Chong. So the screen is yours, Dr. Desmond.
Hi, good morning, everyone. My name is Desmond. I will be your moderator today for this, our second virtual urology webinar. Without further ado, we'll go to our first plenary on urinary stones, unveiling the hard truth of stone disease. It will be given by our surgeon, Mr. Jeffrey Lim. He's our clinical urologist. So I think I think it's very common to see kidney stones, bladder stones, urethral stones. So I think this is a very important topic for us. Let us welcome Dr. Jeffrey. Thank you.
A very good morning to everyone. I am Jeffrey Lim Zekang, clinical specialist from University Malaya Medical Center. Today, I'm going to talk about urolithiasis. Urolithiasis is the presence of stones along the urinary tracts. Epidemiology in Asia is prevalent of 19%. It's male predominant compared to female, 3:1. Typically, it occurs at the age of 30 to 60 years old.
is more prevalent in developed countries with high standards of living. The anatomy of urinary system, the kidney, the collecting system is connected to the bladder where the ureter and the urethra will expel the urine that is stored in the bladder. Any stones in the urinary system is called urolithiasis. Etiopathogenesis. Urolithiasis formed because of anatomical abnormalities, diets that is high in oxalate or high sodium, infection, systemic acidosis, medications, genetic factors, and most common cause of stone disease is inadequate hydration and subsequent low urine volume that cause stone formation. Another slide on etiopathogenesis. There are promoters as well as inhibitors in the urine. The promoters are uric acid, calcium, oxalate, and cysteine. The inhibitors are magnesium and citrate. In the presence of high level of promoters, this will cause supersaturations. On top of that, if the patient has other factors, for example, genetic factors or infection, this will precipitate urolithiasis in the patient. Anatomical abnormalities, for example, patient with vesico-ureteric reflux, patient with horseshoe kidney, neurogenic bladder also increase the risk of urolithiasis. Type of urinary tract stones: calcium oxalate 40 to 60%, calcium phosphate 10 to 20%. So calcium stone is as high as 80 to 90% in urolithiasis. Uric acid around 10%, struwite stones around 20%, cysteine stone 1%. Calcium stone is most common content of urolithiasis. 20 to 80% is white, is hard, is urea opaque. So large staghorn calculi in the kidney, why we call it as staghorn calculi is because it is like the staghorn of deer, right? It's normally calcium phosphate stone, and in ureter it's normally calcium oxalate stones. Uric acid stone, 10 to 20% of the urolithiasis in Malaysia. It is associated with hyperuricemia with or without gout. Radiolucent, they are small, they are friable, they are yellowish in color. Struwite stones are well known as the infective stones. They are constituted of magnesium, ammonium, and phosphate, MAP. They are because of infection from Proteus and Klebsiella. Proteus and Klebsiella, they are urea splitting organism. So basically they cause the urine to be alkaline, forming struwite stones. They are radio-opaque. Cysteine stone, it occurs in cystinuria. It's a rare autosomal recessive condition. They are soft, they are yellow, and they are radio-opaque. The signs and symptoms of a urolithiasis: the patient might present to you with a sudden agonizing pain in your back, side, or groin, typical loin to groin pain. They might have blood in the urine, nausea and vomiting, pain or difficulty in urinating. If the stone is impacted in the urethra, they might have sepsis. If you suspect the patient to have urolithiasis, you should send for blood investigation. Besides kidney functions, to look at the urea and creatinine, to look for any derangement, you should look at the sodium and potassium as well. Also calcium and uric acid, because in a patient with high calcium or high uric acid, you can do something to prevent further stone formations. Urine, you can send a urine dipstick for the patients. So how does urine dipstick help is that you can look for evidence of UTI as well as look for evidence of hematuria or microscopic hematuria in the patient. However, just to take note that if the patient have recurrent hematuria or microscopic hematuria, you should refer the patient to a urologist for further management because it might be a malignancy that you are dealing with. Imaging, X-ray, ultrasound, or CTU. X-ray QUB is for radio-opaque stone. You can see a Stechon calculi. You can see a stent. You can see a stone in the left ureter. X-ray is easily available. 80 to 90% of stones are radio-opaque. However, you might miss around 20% of stones that are radiolucent, just based on X-ray alone. Ultrasound QUB is operator dependent. Mid and distal ureteric stone might not be well seen because of the overlying bowel gas. However, ultrasound is good in giving us the information on hydronephrosis and renal parenchyma disease. Sensitivity of ultrasound for urolithiasis is not so great. It's only about 45%. However, its specificity is high, 94% for ureteral stones, 88% for renal stones. So it's not so sensitive actually, only 45%. CT urogram is the gold standard. However, it's only available in tertiary center. It can delineate the level of obstructions. The sensitivity is 93% and specificity is 96.6%. The stones will be visualized like this hyperdense lesion. The management for urolithiasis. We can divide it into conservative management, medical management, surgical intervention, as well as emergency management. Conservative management means general lifestyle modifications. The fluid intake you should advise for a total amount of 2.5 to 3 liters per day. Circadian drinking, you only ask them to drink during the daytime. They should avoid drinking after 7 p.m. or else they will say you are not a good doctor because they wake up frequently at night just to pass urine. Neutral pH beverages is important. The nutritional advice, most important thing, everything is in moderation. Balanced diet. Diets that is rich in vegetables and fiber. And the myth number one, to prevent urolithiasis, you should reduce the calcium intake. Well, it makes sense, right? Because most of the stones are calcium stones. So by taking less calcium, you reduce the calcium in the urine, hence less risk of urolithiasis. But it's a myth. It's not true. You should advise a normal calcium intake, which is 1 to 1.2 grams per day. If you take low calcium food, it can precipitate stone formation. Advice for normal calcium intake. The thing that you should advise the patient to reduce is salt and also animal protein content. Lifestyle advice, maintain a normal BMI and be active. They should have adequate physical activity, and if the patient is very active or doing a labor job, you should balance the excessive fluid loss on top of this fluid amount of 2.5 to 3 liters. Emergency management. As we can see, you should refer this group of patients to us. Number one, obstructive uropathy, as evidenced by the blood that showed high urea or creatinine, or the ultrasound shows the patient has hydronephrosis. This group of patients have to be referred to tertiary center as soon as possible. Patients who has sepsis, high spiking temperature, because they might have pyelonephritis, they might have emphysematous pyelonephritis or pyonephrosis, which needs urgent intervention. Or a patient with impacted urethra stones, patients who presented to you with difficulty in passing urine, you should refer them to us. In a patient who has obstructive uropathy secondary to urethric stone, we can perform a nephrostomy. This is performed by interventional radiologists, or the urologist can perform a JJ stenting to divert the urine from the obstructed system. Next, the medical management, pain control and medical expulsion therapy. Medical management, you give pain relief in a patient who has a renal or urinary colic. The first line treatment will be NSAIDs like diclofenac. If the patient pain is still persistent, you can give opioids. Medical expulsion therapy is an option. So the myth number 2 is medical expulsion therapy suitable for all patients with renal or urinary colic. For those who don't know medical expulsion therapy, basically the advice is you drink 2 liters of water for the patient, and the doctor will start the patient on alpha blocker like Zatra or tamsulosin for 4 to 6 weeks, and then reassess with an X-ray. Myth number 2, medical expulsion therapy should be offered to all patients with renal or urinary colic. It's not true. It's just a myth. You only offer medical expulsion therapy to a specific group of patients with renal or urinary colic. So the patients have to be no pain, no renal impairment, and they are not septic. If the patient has pain that is refractory, or the patient have deranged urea or creatinine as well as hydronephrosis in the ultrasound, or if the patient is septic like high spiking temperature, you should not start medical expulsion therapy because you might worsen the patient's symptoms and signs. In this group of patients, you should refer them to the urologist as soon as possible. Chemolysis. What chemolysis means is that it changes the medium of the urine, and the agents that we use, it depends on the nature of the stones. The chemolysis drug that most of the doctors will give is like urosachet. So here come to the myth number 3. Should you give chemolysis drug like urosachet for every patient with urolithiasis? Is it myth? Yes, it's a myth. It's not true. So I'm here to debunk this. Why do I say it's myth? It's because chemolysis works by neutralizing the urine pH. Urosachet is alkaline, so it only works if the urine is acidic. From this chart, you can see that the urine is acidic only in a patient with uric acid stone, as well as patients with cystine stone. So urosachet might work in a patient with uric acid and cystine stone where the urine is acidic. So this is only like maybe 10 to 20% of the patients with urolithiasis. Most of the patients with urolithiasis has calcium oxalate stone, and calcium oxalate stone, whatever you give, is not dissolvable. Why you should not give urosachet for every patient with urolithiasis is because if the patient has 2 white stones, well known as infective stones, where they have alkaline urine, by giving urosachet, which is alkaline, you make the pH to be even higher, and this will actually precipitate more stone formations in a patient with true white stones. So debunk myth number 3, urosachet for every patient with urolithiasis. It's not true. You only give it to patients with acidic urine, which is patient with uric acid stone and cystine stone. please check the urine pH before starting urosachet. Touching a bit on method of stone removal. First is ESWL. It's a non-invasive treatment. It can be performed as day care. The patient come in the morning, they can go back in the afternoon after the session. The patient will lie on a bed. We can identify the stone using an X-ray or using an ultrasound machine. With coupling mechanism, this will deliver the shock wave to the desired stone and break the stones. The indication of ESWL is stones that is less than 1 cm in kidney as well as in the ureter. If the stone is 1 to 2 cm, you can still go for ESWL, but the patient might need extra treatments or procedures after the ESWL. Percutaneous nephrolithotomy or PCNL. How we do it is that we puncture the collecting system, dilate it, and introduce an instrument, nephroscope, to break the stones. PCNL is only reserved for stones that is more than 2 cm or lower pole stone more than 1 cm. Because of the invasive natures of PCNL, it is associated with higher risk and complications. Ureteroscope. This is a semi-rigid ureteroscope. This is a flexible ureteroscope. Semi-rigid ureteroscope is for stones in the ureter, and flexible is for stones in the kidney because it is flexible. You can flex it up, down, left, right. Complications is low, less than 1% of urinary injury and strictures. Just a bit of cartoon on URS. As you can see the stone here, we can remove it just by using a basket. Or if the stone is quite sizable, we can use a laser to break the stones and use a basket to remove all the stone fragments. Cystolitholopexy means breaking up the bladder stones into smaller pieces and remove them. You can use the energy like laser, or you can use a mechanical crusher like Mayo Mayer. And important for us to treat the underlying pathology, because bladder stone normally is due to bladder outlet obstructions like prostate problem, like benign prostatic hyperplasia. So you should sort out the causative problem, which is a prostate, by transureterization of prostate. This is the mechanical crusher, Mayo Mayer. We open up the jaw and then we crush the stones into small pieces and remove them. Another method for huge bladder stones is percutaneous vesicolithotomy. Generally, huge bladder stones, you need to do an open procedure to remove the stones. However, PCVL can be alternative, where we puncture through the suprapubic region, dilate the tract, and put in a huge device like nephroscope to break the stones and deliver them. Open procedures are getting lesser now because of advancement in the technology and also device, as well as this energy device. In a patient with huge bladder stones, typically they have to go for vesicolithotomy, where you have to make a big cut in the lower abdomen, open up the bladder and to deliver the stones. However, now, as what I've mentioned earlier, PCVL can be an alternative. Take home message: patient with urolithiasis, the recurrence is 15% in 5 years. So you need to approach the patient, multimodal approach. Not only about surgery, important about lifestyle modifications. And most important is to keep hydrated. That ends my presentation. I thank you everyone for your attention. This is my email. If you have any queries, you can always email me, or else you can ask me live.
Thank you very much, Mr. Jeffrey, a very extensive talk about stone disease in our population. So I think there are a few questions here we would like to address to Mr. Jeffrey. So we will screen through, and I think this is our first question here will be how to know the type of stone for specific therapies.
Well, regarding the specific type of stones, you won't really know it for sure unless the patient has the stone after it's passed out, or the surgeon or urologist retrieve the stone and send this stone for stone analysis, which is available in UMC and not easily available in other hospitals. They have to pay around 100 to 120 bucks for the stone analysis. So in general, I don't think you can know the specific type of stones. So your lifestyle modification and advice would be based on the general one, you know, to prevent calcium oxalate stone, to prevent uric acid stone, as well as to prevent these steroid stones. You wouldn't know for sure until you send it for stone analysis to answer your questions.
So I guess prevention is always better than cure, right? So we will not want to go into that, and so we must prevent it as a first line. So anyway, the next question will be, they advise not to take too much water, more than 1 liter, as it will cause hyponatremia. But here it is advised to take 2 to 3 liters of water to prevent urolithiasis. It is a contradict statements. So I think maybe Mr. Jeffrey, can you help to answer this question?
All right, yeah, sure. I mean, definitely the water intake part is always a myth. But if you are a healthy adult with no any contraindications of volume of water to be taken as by doctor, you should drink 2 to 3 liters of water per day, because that is the fluid requirement for every healthy adult. You need to ask the doctor why you are not allowed to drink more than 1 liter of water. Because if you have heart problem or you have endocrine problem, like patient with this syndrome of inappropriate ADH secretion, antidiuretic hormone secretion, they might want to limit you, because if you drink too much of water, that might cause hyponatremia. I'm not sure what is your disease, but in general, you should drink 2 to 3 liters of water unless your heart cannot take it because your heart is weak. They limit you to 500 cc or 1 liter of water, or maybe you have some endocrine problem. If there's none, you should not restrict yourself from drinking just 1 liter of water per day, because that is actually very, very suboptimal. Yeah, so you have to always double check with your doctor what is the reason you are being restricted fluids. Because if you say, if you are healthy, you are young, if you are healthy, regardless of your age, drinking 1 liter of water should not cause you will cause you to have problem, and by drinking 2 to 3 liters of water should not cause you to have hyponatremia, because it wouldn't, it shouldn't. Yeah, so you should drink 2 to 3 liters of water. Ask your doctor why.
Agree. I think our body mechanism will that it will balance out the sodium as well, right?
Yes.
So yeah, so I think unless you got kidney problem, heart problem, or anything, or endocrine problem. Anyway, we'll go to the next question. For medical espousal therapy, is if other alpha blockers like terazosin is acceptable as an alternative to tamsulosin if it is not available readily in the GP setting?
All right, good question. Yeah, definitely terazosin is an acceptable alternative. It's just that you need to warn the patient. The patient might have a bit more side effect because it's not a selective alpha-1 blocker. But terazosin is actually a good alternative of tamsulosin if you don't have tamsulosin in your clinic. Yeah. Okay. But just remember, you only give medical expulsion therapy in a patient who has no pain, no sepsis, as well as no obstructive uropathy. Yeah. If there is any of those symptoms or signs, you have to refer to tertiary center as soon as possible.
Okay, so next we go to the next question is regarding bladder stones. What size of stones that we need to refer urologists if patient asks? I think because nowadays ultrasound is readily available in a lot of the clinics, and I think it is they can easily scan bladder stones. And what size do we need to refer to urologists, and what size does it need to be managed?
Oh, okay, all right. So this is an interesting question because bladder stones and bladder bladder stones and renal stones, they are of different etiology, you see. So whatever that we talk just now is mainly on etiopathogenesis of renal stones, but for bladder stone, they actually occur normally because of either a bladder outlet obstruction, that means that the outflow, there is some impairment, or because the patient has a neurogenic bladder, that means the bladder cannot contract well, so there's always stagnant of urine in the bladder. So irregardless of the size of the stone in the bladder, they should be referred earlier. The reason why is because the patient might have a bladder outlet obstruction, for example, like prostate problem, or for example, like urethra stricture, that patient unable to pee well or empty the bladder well, or the patient has a neurogenic bladder, the bladder cannot empty well. So any size of bladder stone that you pick up in your clinic, please refer the patient to tertiary center for more checkup to determine what caused the patient to have bladder stones, so that we can tackle the bladder stones as well as the underlying pathology at the same time. For example, prostate. We need to crack the bladder stone, and then we can do a TURP to resect the prostate so that we can give a good channel for the prostate.
I agree. So I think the main thing is about whether this is a primary bladder stone or the secondary bladder stone. And if the primary bladder stone, we need to investigate further as well, right?
Yep.
So I think the next question is, in many GPs setting, Rowatinets is commonly used and is commonly practiced. What is your take home on this regarding Rowatinets?
I see. Yeah, actually, I have a lot of patients who say, you know, they are being prescribed Rowatinets. Rowatinets is good. But actually, there is no any good level 1 or 2 evidence that shows that Rowatinets is associated with higher chance of a stone expulsion. So basically, a bit on the drug mechanism is that it reduces the muscle spasm, right? It can reduce the pain of the patient if they have this colic. But muscle spasm and also this relaxing the smooth muscle of the ureter can be achieved by alpha blocker as well. So it doesn't really give extra advantage as compared to alpha blocker that we are giving. And most importantly, there are no any high level evidence that shows that Rowatinets works. I do understand that some people say that, you know, some doctors say that it reduces inflammation, it increases the blood flow and things like that, but it's not exactly proven. So we always go back to evidence as well as the guideline. It's not routinely advised to give Rowatinets. Alpha blocker is good enough if the patient has colics. Yeah.
Okay. So next, a question on URO sachets. In what scenario do we provide long-term URO sachets?
Okay, all right. Yeah, I appreciate the question because a lot of patients are on URO sachets for long-term. Yeah, but strictly speaking, you don't really need to give a URO sachet for long-term unless you have persistent acidic urine, right? For example, in a patient with this uric acid stones, or in a patient who has in a patient with persistent acidic urine. So don't think there's any indications for you to be given on a long-term URO sachet. URO sachet is only a temporary measure, yeah, until we have cleared the stone for you, or unless you have a high uric acid which is not well controlled and your urine is persistently acidic. So after we have cleared the stone for you, we want to make sure that your urine pH is on the neutral pH. Then we might prescribe you with a URO sachet for long term to prevent further stone formation. But other than this group of patients, I don't think there's any role for long term URO sachet besides a patient with uric acid stone with acidic urine pH. Yeah.
Next, there is a question on urethric stone. What size favors medical expulsion therapy, and after given medical expulsion therapy, if it doesn't work, when do we need to refer?
Okay, all right, good question. So actually for this medical expulsion therapy, you only give it for patient that has stone more than 5 millimeter. Any stone that is less than 5 millimeter in the ureter, especially distal ureter, 95% of the stone will be passed out if it's less than 5 millimeter. So medical expulsion therapy will increase the chance of expulsion of stone if the stone is more than 5 millimeter, especially in distal ureter. Regarding what is the maximum size that you can give, there's no any guideline to mention about that, but generally 1 to 1.5 cm stone in a patient who have no pain, no sepsis, no obstructive uropathy, it's safe for you to try medical expulsion therapy. But if the patient still have persistent pain, despite started this medical expulsion therapy, or sepsis or obstructive uropathy, you have to refer the patient to tertiary center as soon. Yeah.
All right, thanks. So the next question is, what is the best imaging modality for a patient with renal colic? If you can see a stone on the X-ray initially, should we go for ultrasound or should we go for CT scan? And yeah, what's the best that we should do?
Okay, I mean, it depends on what is the facility that you have. If you can see there's a stone in the X-ray, right? It's always good to have an ultrasound to visualize is there any evidence of obstructive uropathy. Because X-ray is only good for you to see the stone, but you're not sure whether does the patient have a complication of the stone, like hydronephrosis or hydroureter, which suggests obstructive uropathy. So if you have an ultrasound facility available, it's always good to have ultrasound, even though you have identified the stone in the X-ray. But if you doesn't have it, and the patient has no more pain, you want to try some conservative management, you can still try, but always warn the patient that if the patient has any worsening pain, fever, then you have to get them to get the ultrasound and refer to hospital as soon as possible. Yeah.
Okay. So I think going back to the question on water intake, there are people who advise not to take mineral water. What's your take on that?
Not to take mineral water. It's all right, no worries. Water you can take, either it's mineral water or distilled water, anything you can take, all right? I think the main concern of us about this intake is not water, right? It's the food that we are taking, because our food nowadays are mainly processed food. It's high salt, high protein kind of food. So I think we have to worry more on our food intake rather than water intake, because the ingredients or the contents of sodium or other electrolytes in the water is actually minimal. Yeah. So mineral water, you can still take it. Yeah. Just make sure that you're drinking 2 to 2.5 liters of water per day. That will be good enough. Yeah.
I believe if you don't have any kidney problems, your body will have a normal homeostasis. So it will help to actually regulate it. So the next is, I think this is a very interesting question. How to balance between not overtaking calcium in the diet or supplement as part of the treatment for osteoporosis against the risk of promoting calcium stone from overtaking calcium orally, sorry.
Okay, all right.
Yeah.
So basically you're asking about how much is too much, how much is too little,
yes,
especially you have underlying osteoporosis, right?
Yes.
Well, to begin with, if you have osteoporosis, besides age factors as well as your hormonal factors, you are not taking enough calcium. That's why you have osteoporosis. Okay, so to be exact on how much calcium you should take, there's always a calculator. You can get the apps online to check how much is the calcium content of food that you're taking. So besides natural food, if you're osteoporotic, you should supplement yourself with calcium as well and a vitamin D. Okay, so you need to have a calculation of the total calcium intake per day. And you can only do it if you have idea of how much calcium in the food that you're taking as well as your calcium tablet. So you need apps or a calculator to actually help you to calculate that. It's very hard for you to just agak-agak. You need to have a proper documentation as well as a proper calculation. But if you are osteoporotic, you should definitely increase your calcium intake to the specific desired level. Yeah, and you have to perform your DEXA scan to check on your bone mineral density along the way to make sure that you are on the right track. Yeah.
Okay. I think due to due to limited time, so I think we will answer the questions in the chat box later. We will try to answer all of it. Thank you, Mr. Jeffrey, for the extensive talk about urinary stones, and thank you for the explanations that I think we all have in our minds. Thank you.
Thank you. Thank you so much.
So due to limited time frame, we will go to the next topic on working up a patient with hematuria. It will be given by Prof. Shanga, our current consultant urologist in UMMC. He is our current head of surgery department for PPUM. Without further ado, we would like to invite Prof. Shanga for the talk.
Hello everyone. Thank you for joining this webinar organized by the Urology Division of the University Malaya Medical Center. I'm Dr. Shanga Kupusamy, a consultant urologist at UMMC. Today, I will be talking about blood in the urine, which is known as hematuria. This is a very important topic on a very common condition that requires proper workup and management so that we don't miss something sinister. To dispel all the misinformation out there, my talk today will concentrate on giving some facts about hematuria so that I can refresh even the simple things for you. I will be talking about the causes and the risk stratification so that we don't over-investigate and also not to take it lightly. I will also be touching on the ways to proceed when dealing with these patients by taking thorough history, focused examination, and investigating them. Furthermore, I will also be giving you an idea on the referral pathway to the urology unit and what do we do when we receive your referral. Hopefully, this will help you counsel your patients better. Before we go further, let's look at some simple definitions and how the patients would present. Firstly, non-visible or microscopic hematuria. This is when you can't see the blood in the urine and the urine usually appears normal. The blood is identified only by some tests like the urine dipstick, where a chemical reaction changes the color on the stick, or the urine can be subjected to in the urine analyzer machine that you might have in your clinic. Once the urine dipstick is positive or there is evidence of microscopic hematuria, the urine is usually sent to the laboratory where a microscopy is performed and red blood cells are identified and counted for significance. Significant hematuria is said to be at a level of more than or equal to 3 RBCs per high power field. Next is the frank or gross hematuria, or also known as macroscopic hematuria, where we can see the blood with our own eyes. Sometimes there's presence of clots even. It just means that there's a lot more blood in the urine. Now, what are the causes of hematuria? They can be divided into glomerular causes or non-glomerular causes. The glomerular causes arises from problems within the glomeruli of the kidney and mainly due to medical causes like IgA nephropathy, glomerulonephritis, which are dealt with by our medical colleagues. We will concentrate today mainly on the non-glomerular causes, which are usually surgical causes that arise from the renal tubules right up to the urethra. These are conditions that are handled by the urologists. To classify further based on location of the problems that give rise to hematuria, it is best to use the anatomy model of the urinary system. Conditions can be arising from the kidney, like renal cell carcinoma, pyelonephritis, and renal stones. They can also arise from the ureter, bladder, and the urethra, and where they can have conditions like urothelial cancer, either in the ureter or the urinary bladder. They can have stones, can have urinary tract infection, or even hemorrhagic cystitis, which can be precipitated by previous radiation therapy. As far as the prostate is concerned, conditions like BPH or BPE, benign prostatic enlargement, or even prostate cancer can present with hematuria. There are several other less common causes like exercise-induced hematuria, idiopathic causes where the causes are unknown, and even due to food intake like beetroot, which can cause reddish discoloration of your urine. Fortunately, although it must be scary for someone to have blood in the urine, we can reassure our patients that most of the time the reason is benign, especially with microscopic hematuria. When someone has frank or gross hematuria, the likelihood of cancer increases. Evidence suggests that in the UK, about 8% has urinary tract stones, 10% of patients with hematuria has urinary tract cancer. What about Malaysia then? In Malaysia, data has shown that only 1% of patients with microscopic hematuria had cancer, and 5% of those with hematuria, 5% of those with frank hematuria had cancer. So, almost 90% of cases has benign cause, and we may not need to do any unnecessary investigations even. In working up these patients, we must first take a proper history. The old medical school teaching of painless hematuria equals cancer until proven otherwise, especially in the elderly, still holds good. Like I said earlier, frank or gross hematuria means higher risk of malignancy. So in the history, we have to ask for history of flank pain, dysuria, which may be due to infection or stone with or without fever. Presence of lower urinary tract symptoms like hesitancy, poor stream, urgency, or frequency of micturition may indicate benign prostatic hyperplasia. The presence of hematuria at the beginning of the stream may indicate pathology in the urethra, and if noted throughout the stream, it may show a more proximal pathology like in the bladder, ureter, or the kidneys. Exercise or previous instrumentation or recent instrumentation needs to be asked. History of radiation or chemotherapy like cyclophosphamide use increases the risk of hematuria or caused by bladder cancer. Risk factors like smoking, occupational history, like especially those working in the chemical industry, oil and gas industry with exposure to aromatic amines may contribute to malignancy risk as well. Apart from that, family history and systemic symptoms are elicited. We should examine the patient by looking for anemia, examine the abdomen for any mass or tenderness, not to forget a digital rectal examination in male who are above 40 years old to look for suspicions of prostate cancer. As far as investigation is concerned, urine analysis with renal profile, full blood count, and other investigation that may be prompted by the problem at hand can be advocated for our patients. There are varying guidelines in the workup algorithm for hematuria patients from all the different urological societies around the world, especially in cases of microscopic hematuria. For frank hematuria, because of the higher risk, the referral pathway is established and has a lot of similarities according to the guidelines. Now, allow me to suggest to you my way of systematically working up these patients, taking into consideration all the recommendations of the said guidelines of the societies. First of all, taking into account the urine analysis that shows hematuria, I would look for abnormal RBCs, proteinuria associated with the presence of renal impairment. If present, I would first refer to my nephrology colleagues to work up the medical causes, because this may indicate glomerular bleeding actually. If there are normal RBCs, plus or minus proteinuria, doesn't matter, because infection can present with proteinuria as well, with some clots even, then I would think of non-glomeruli bleeding. Okay, so first I would like to rule out benign causes. And what is that? The first thing that comes to my mind is it UTI that I'm dealing with? If there is presence of UTI symptoms, raised leukocytes, leukocyte esterase and nitrites present in the urine, I would then take urine cultures and treat them empirically with broad spectrum antibiotics till the culture comes back. If no, then I would think of whether is it urinary tract calculi that I am dealing with. Okay, so they can be symptomatic or asymptomatic. Their urine can have leukocyte esterase, crystals, nitrites, and they may have low pH. Their urinary pH could be low, which is usually present in uric acid stones. If yes, then we should do a KUB X-ray or a non-contrasted CT urography. So this is a KUB X-ray on the left, and on the right is the non-contrasted CT urography. These images show a radio-opaque shadow at the left kidney area on the KUB X-ray, indicated by the blue arrow, whereas the right image shows a CT scan with stone at the right renal pelvis as shown by the white arrow. Depending on the size and location of the stone, we can either treat the stone conservatively by just watching, do a litholopexy for bladder stone, ureteroscopy either rigid or flexible for ureteric or renal stone, or sometimes we can even use ESWL or a more extensive operation like PCNL, which is percutaneous nephrolithotomy. If there is no stone, then we now have to consider another benign condition like PPH based on the age and presence of lower urinary tract symptoms. BPH or BPE is a condition when the prostate enlarges with increasing age and obstructs the urinary flow. This gives rise to lower urinary tract symptoms that can be either voiding, which is hesitancy, delayed in starting of micturition, poor flow, poor stream, intermittent flow, terminal dribbling, or patients may have storage problems like frequency and urgency of micturition, or they can even have nocturia. These patients can also have hematuria due to straining and also bleeding from the surface of the prostate when they have difficulty to pass urine. So, if there is BPH, then the patient can be treated with medical management using alpha blockers, 5-alpha reductase inhibitors, and if this medical management regime does not help the patient, then they may need surgical intervention like a TURP or known as TURP. Okay, but not to forget, when we have patients who we think may have BPH and also having hematuria, always have concurrent upper tract assessment, especially if the hematuria is persistent. So, if there is no suspicion of BPH, then the next is the situation where a patient might develop hematuria after vigorous exercise, if the history suggests so. Especially in patients who does long distance running or extensive sit-ups. Okay, so it is advised that best is to drink water before starting and don't empty the bladder before starting. Okay, to avoid the bladder wall. When the bladder is empty, the bladder wall may rub against each other and cause hematuria because of the strenuous activity. If that history is ruled out, so that means all the benign conditions are ruled out, common benign conditions, then the patient has to be risk stratified. All established guidelines give risk stratification and they are mostly similar. It is most important to risk stratify just to avoid unnecessary tests. Low risk patients are are those who meet all the following criteria, which are women aged less than 50, men aged less than 40, they are non-smokers or less than 10 pack years of smoking, they have 3 to 10 RBCs per high power field, and they don't have any other risk factor for urothelial cancer. Whereas intermediate risk are those who have any one of the following, which are women aged 50 to 59 years, men aged 40 to 59 years, smoking history of 10 to 30 pack years with 11 to 25 RBC per high power field, and they do not have any other risk factor for urothelial cancer. Finally, high-risk patients are those who fulfill any one of the criteria of women or men aged more than 60 years old, with smoking history of more than 30 pack years, with RBC of more than 25 per high power field, with history of frank hematuria. Let me talk about low-risk patients first. Usually a repeat urine analysis at 4 to 6 weeks is recommended. If the microscopic hematuria is persistent, then these patients should be following the protocol for intermediate risk, which I'll be talking about in my subsequent slide. But the only difference may be only to do an ultrasound as the choice of imaging modalities for these patients. If the repeat urine analysis is negative, then no further workup would be required, but can advise the patients to come back if they notice any frank hematuria, or repeat the test in 1 to 2 years' time. If the patients are categorized into intermediate or high risk, then they must undergo a cystoscopy to look into the bladder, and a multiphasic contrast enhanced renal CT scan is mandatory. The use of urine cytology is still optional, as the sensitivity and specificity is only good for high-grade urothelial cancers. Now, this is how we perform a cystoscopy. A flexible cystoscope is inserted into the bladder under local anesthesia. It may just take about 5 minutes to perform, and a bladder tumor, as shown in the image on the right, is visualized within the bladder. If bladder tumor is diagnosed, then the patient may be subjected to TURBT, transurethral resection of bladder tumor, or radical cystectomy, depending on the grade and depth of the bladder lesion. If in the CT scan a renal tumor is found, as shown in the CT images here by the blue arrows on the left and the right, then patient may have to undergo a radical nephrectomy to remove the kidney. However, if the lesion is small, then it is also safe to observe the mass with regular surveillance with CT scans, or a partial nephrectomy can be done. The next possibility is the upper tract urothelial cancer, or also known as UTUC. This is a cancer that occurs in the lining of the ureter and collecting system in the upper tract. This is a less common type of cancer compared to the renal cell carcinoma or bladder cancer, but it is considered to be more aggressive. If UTUC is noted early, we can actually ablate it using the laser therapy, but in most cases, due to the aggressive nature, we have to perform a radical nephrouretrectomy, which involves the removal of the kidney, entire ureter, and the cuff of the bladder. After all these investigations, if there is still no diagnosis established, then we should advise the patient to repeat urine analysis yearly, or reinvestigate if there is repeat episodes of frank hematuria. With that, I would like to summarize my presentation by just mentioning that hematuria may not mean that the patient is having any major problem, but having said that, we should not ignore blood that is present in the urine. And we should reassure the patients that the most common diagnosis in hematuria are usually benign, and the most important investigations to be performed is a cystoscopy, and we can choose either ultrasound or CT scan as our imaging modality based on risk stratification. And if there's a serious problem like cancer identified, then finding it early can save lives. With that summary, I would like to thank you for your attention.
All right. Thank you very much, Prof. Shanga, for the extensive talk on hematuria, whether it is microscopy or macroscopic hematuria. So I think for my personal learning is that if there is a microscopic hematuria, it is important to see whether it is what's the high power field, whether it is more than 3 or it is less than 3. If it is less than 3, I believe here it is not a microscopic hematuria. But I think in the GP setting, a lot of times we are using urine dipstick. So I think our first question here is that in what circumstances do we pick ultrasound KUB or the CT scan, whether contrasted or non-contrasted, for microscopic hematuria?
Thank you, Desmond. Yeah, that is a very important question. I would have addressed it in the talk just now, that risk stratification is the most important aspect to determine what type of investigation that you would like to do. So if it is low risk, then we should low risk and it's persistent microscopic hematuria, then we should choose ultrasound as our main imaging modality that you want to use. But if you have intermediate or high risk, then intermediate as usual is always equivocal whether we use ultrasound or CT scan. You can actually choose either. But if it is high risk, then you should definitely go for CT scan. Multiphasic contrasted CT scan is the best mode of investigation as far as imaging is concerned.
All right. So it will be a contrasted CT scan multiphasic.
Yeah.
Okay. So the next question will be, for vigorous exercise, what is the duration or how recent vigorous exercise has to be? So I think this has been answered previously, whether we will need to re-stratify the patient, low risk, moderate risk, or high risk, and what is the possible cause for the hematuria in vigorous exercise. I think, yeah, I think this one will be rhabdomyolysis or something. Maybe Prof. Shanga, can you help to answer this?
Not so much rhabdomyolysis actually. So I think one of the questions in the on this matter is first of all, when do we think it is caused by exercise actually, isn't it? So when a patient presents, like, you know, they must have exercised a month ago, and of course that may not be relevant anymore. There's no guideline to answer this question, but most of the time it is within 48 hours. If the hematuria happens within 48 hours of an exercise, then it can be accepted, maybe having some causal effect due to the exercise itself. But with regards to reason why, they always say it's the walls rubbing. That's why I say if you empty your bladder just before starting an episode, an exercise event, then the rubbing of the walls of the bladder when you strain your lower abdomen, then it may cause hematuria actually. So I think you should always have good hydration when you start or before you start, and also sometimes infection can cause and you do what do you call that, when you have a mild urinary tract infection, when you start doing exercise on top of possibility of infection in the bladder, then of course you'll be at more risk of developing hematuria.
Okay. Next, there will be a question on urine cytology. So how do you interpret urine cytology if we send it for persistent microscopic hematuria, and what findings does it suggestive of malignancy?
Okay, cytology is very difficult to interpret as with regards to the sensitivity to pick up any malignancy in the urinary tract. as we understand, we should look for atypical cells, atypical urothelial cells, okay, which is something that is shed from the urinary system. If there are any atypical cells, sometimes our cytopathologists can actually identify malignant transitional cells actually within the urine cytology specimen. So if those cells are there, atypical plus malignant cells reported directly by our cytopathologists, we should open up our eyes and immediately refer them to the urologist.
Okay, I think so. I think if there is something suspicious, it will always best to refer to your urologist from the urine cytology. So the next we will go to, the next question will be, do we refer hematuria cases to nephrologists or urologists?
Okay, this is a very $1,000,000 question actually. Okay, so always look at the causes. Yeah, the causes. If you think that the urologist, you have suspicion that it may be a urological cause, of course, you should refer to the urologist, like presence of stone. My colleague Jeffrey spoke about extensively how to work up stones and treat stones. If you think it is recurrent UTI, if it's a minor form of UTI, you can treat yourself. You don't need us or a nephrologist to handle these patients. And if you think the UTI is recurrent and persistent, difficult to manage with straightforward empirical antibiotics, then by all means refer to the urologist. And anything more than that, like BPH and suspicion of malignancy, of course, please do refer to us urgently. With regards to the referrals to nephrologists, if there's no findings that may be may need management by urology team, then of course you need to refer to the nephrologist. And of course, patients with renal impairment, abnormal RBCs, abnormal RBCs are reported, so you can use those indicators to decide whether you should send the patient to the nephrologist.
Okay, all right. The next question will be, ultrasound scan examination is equipment and operator dependent. In GP setting, do you advocate us as a GP to refer diagnostic workup at a tertiary institution?
I think most of our GPs, fortunately nowadays, our GP colleagues are all very well trained in performing ultrasound. They do attend courses, and they are actually well versed with ultrasound usage. I think initial screening of ultrasound is actually can be done by the GPs themselves. You know, at your setup, please go ahead and do your ultrasound because you are trained for that. You have gone for courses. You are trained for that. I think initial screening is very, very feasible on your part. Please go ahead and do it. And if you find any abnormality and if you have any reason to believe that you are unsure of certain things, and then you can just refer to get a formal ultrasound at a sonographic center, actually.
Okay, all right. A lot of questions are coming in. So the next question is over-distended bladder a cause for benign hematuria?
Okay, just now I mentioned a collapsed bladder with rubbing of the wall causing hematuria, actually. So over-distended bladder sometimes should not cause any problem, actually, over-distended bladder. But when the bladder is stretched beyond a certain limit, then of course all those capillaries that line the bladder wall, sometimes they release some RBCs, you know, into the urine. So that can be the one condition. And sometimes when we suddenly decompress an over-distended bladder, they usually, all those capillaries, then again, they start bleeding. This is what we see in our practice. And so, yes, it can sometimes cause hematuria in patients with persistent over-distension of bladder.
Okay, so I think we will take the last question as due to we have limited time frame. So what is the immediate management when patient came to clinic kesihatan with gross hematuria? Patient don't have any pain. Should we refer for bladder irrigation?
Yes, of course. Patient, as I said, medical school teaching, painless gross hematuria is cancer in the urothelial urinary tract until proven otherwise. And you best is to refer the patient for catheterization and irrigation in order to prevent clot retention. The patient may go into clot retention because of blood in the stasis of the blood in the urine within the bladder. So you may end up with having an emergency actually. So please do refer any frank hematuria because they are immediately considered high risk. Okay.
Okay, I think the important is that we must rule out whether it is an acute urinary retention and do the immediate treatment for that and refer. Okay, thank you, Prof. Shankar. This is, I think due to limited time frame, we'll try to answer the other questions in the chat box. Thank you.
Thank you very much.
Okay, we will go to our next topic on conquering benign prostatic enlargement and the role of phytotherapy by Mr. Muhammad Fairuz Shah. He is our clinical urologist in UMMC. Please welcome Mr. Fairuz.
Assalamualaikum and very good morning to everyone. My name is Muhammad Fairuz Shah and I'm from Urology Unit, University of Malaya Medical Center. First of all, I would like to thank the organizing committee for giving me a chance to give a talk about conquering BPE and the role of phototherapy on its management. Let's start with the introduction. Benign prostatic enlargement, or also known as a BPE, is one of the causative factors for the man's LUTS. In Malaysia, the prevalence of men that are affected with BPE is around 35 out of 100, in which more than 50 years old of age. This issue is mainly involved into a middle-aged man and the elderly aged man's population group. I would like to ask these questions and issue whether it is possible to treat a BPE patient in my own clinic and primary healthcare, as I believe majority of the participants in this talk today is from a general practitioner and a primary healthcare level. The good news is the answer is yes. Let's see what is the issue in treating a BPE at the primary care or the GP level. As we all know, the BPE is a common issue that involve middle-aged and elderly men. Usually, this group of patients have a similar period of follow-up with other comorbidities, examples of diabetes and hypertension. By reviewing a patient in a similar follow-up, this can reduce a BPE follow-up in the urology center, especially for case of mild and uncomplicated case. Which patients are suitable to be treated in a GP or primary healthcare level? The criteria is a simple or MyIPSS score patient. Next is a stable disease or no risk of carcinoma of prostate, or last but not least, there is no risk of progressions of disease or the need for surgery in terms of treatment for BPE. I have divided the issue of treatment of BPE in a GP level into a few subcategories as mentioned here. The first one is, how do I diagnose a BPE case? Number 2, what investigation should I do for them in my own clinic? Next is, what medication can I prescribe to a BPE patient? Number 4 is, how should I monitor them? And last but not least, when should I refer a case of BPE to a urology center for a further assessment? Before we discuss about the issue, let's just define about what it means by LUTS or lower urinary tract symptom. LUTS is divided into 3, in which consists of storage symptoms, avoiding symptoms, and post-maturation symptoms, as you can see on the right hand graph. If the Lutz symptom is worse, it can impair the quality of life to those patients with the BPE syndrome. It can be a multiple cause, and one of it is due to the obstructions secondary to benign prostatic enlargement. And in case of moderate to severe Lutz, a patient may have an increased risk of major adverse cardiac event as one of its complications. As we have discussed before, there are several factors that can contribute into a male Lutz symptoms, and in this presentation or in this talk, we will concentrate more on benign prostatic obstruction, or also known as a BPO. Let's define a bit about few definitions that are related to men's Lutz. The first of all is acute retention. What it means by acute retention is a painful and palpable bladder due to unable to pass urine. On the other hand, the chronic retentions mean it's non-painful, palpable bladder even after the patient has passed urine. What it means by bladder outlet obstruction, or also known as a BOO, is defined as obstructions during voiding that are characterized by increased detrusor pressure and reduced urine flow rate. If the obstruction is due to a BPE, it is called as benign prostatic obstructions, or BPO, and last but not least, benign prostatic hyperplasia is a typical histological pattern or definition for a BPE. Let's move on to a issue to discuss about treatment of BPE in our own clinic. We will start with how do I diagnose a BPE case. As common and other disease or condition, the diagnosis of a patient or disease started with a history taking. The first of all is to assess the Lutz severity based on the IPSS score, which will be discussed subsequently. Next is to take a medical history and neurological history, especially or examples as a diabetes mellitus. A sexual functions, examples as erectile dysfunction, retrograde ejaculation, or decreased libido is also one of the important history in assessing a Lutz symptoms. Furthermore, family history of prostate cancer has made the patient to have a high risk of developing a prostate cancer itself. And last but not least is to review the current medication and the lifestyle habit, as this can also affect the Lutz symptoms to a patient. Let's talk about International Prostate Symptom Score, or also known as IPSS. IPSS consists of 8 items, in which 7 symptoms and 1 quality of life. It is a validated questionnaire that consists of few categories as mentioned in the slide. If the score is between 1 to 7, is considered as mild. Next is between 8 to 19 is considered as moderate, and last but not least, if the score is more than 20 is considered as severe. This questionnaire is easily available online as a calculator in which a doctor can actually fill in, and then after that can get the score immediately. These are again the manual forms of the IPSS, and the guidelines mention that use a validated symptom score questionnaire including border and quality of life assessment during the assessment of male Lutz and the evaluation of the patient after treatment has started. Next is about physical examination and digital rectal examination. As again common to other disease and condition, physical examination is one of the main criteria to diagnose a disease. In terms of Lutz symptoms, suprapubic area examination to detect a palpable bladder, external genitalia and perineum is one of the important examinations during the assessment. Let's talk about digital rectal examination. DRE is used to detect any suspicious features of prostate cancers that are available, examples as a nodule or heart inconsistency. It is also used to approximately assess the prostate volume, based on the physical examination. Let's move on to the next issue of what investigation should I do for them in my own clinic to diagnose a patient with a BPE. We will start with the basic and simple investigation first, is to start with urine analysis. Urine analysis or urine FEME is used to detect any condition, examples as urinary tract infection or UTI, diabetes mellitus or microhematuria that can actually contribute into the male load symptoms. Next is about the PSA, or also known as a prostate-specific antigen. The study has shown that there is an association between the PSA and the prostate volume, especially if the level is more than 1.5. It is a predictor of prostate growth and will actually inform or tell you that this patient having a clinical progression. It is also used as predicted for risk of acute urinary retention or AUR and the need for BPO-related surgery in the future. The risk of treatment was higher in men with a baseline PSA of more than 1.4 nanogram. In terms of blood investigation, next is to send for renal function test, or also known as renal profile. This consists of serum creatinine and estimated glomerular filtration rate, or also known as eGFR. If the patient have a bladder outlet obstruction, this would lead further into a patient developing hydronephrosis and renal insufficiency secondary to a urinary retention. Elevated creatinine level in the assessment is one of the requirements for a patient to undergo the ultrasound KUB. Bladder outlet obstruction can lead into obstructive uropathy and subsequently lead into a renal impairment. Let's move on into imaging that can be done in our own clinic. I believe nowadays most of the GP has ultrasound machines available in their own clinic. The first one is to start with the ultrasound KUB. What is the use of ultrasound KUB is to assess the prostate volume and the PVRU, or also known as post-voidal residual urine. Next is to detect whether the presence of any bladder calculi or hydronephrosis secondary to the obstruction. Last but not least is something called intravesical prostatic protrusion, or also known as IPP. How do we measure a prostate volume based on the ultrasound scan? It is calculated based on this ellipsoid formula, which consists of length multiplied by height and multiplied by width with a constant of 0.52, as shown in the right hand side of diagram. The normal value is around 20 to 30 cc of prostate. You can see on the right-sided diagram in which a maximum transverse diameter and a longitudinal diameter and anterior posterior diameter was measured based on the ultrasound scan. Let's talk about the intravesical prostatic protrusion, or also known as IPP. What is IPP stands for? IPP measures the distance between the tip of the prostate median lobe to the bladder neck in mid-sagittal plane, as shown in the right-hand side diagram. It is divided into 3 grades, in which grade 1 is considered as less than 5 mm, grade 2 is between 5 to 10, and grade 3 is more than 10 mm. Let's next move on to the what medication or treatment that can I prescribe to a patient with a BPE. The first one is an alpha-1 adrenal receptor antagonist, or also known as an alpha-1 blocker. The alpha-1 blocker mechanism of action is by inhibiting noradrenaline on the smooth muscle cell in the prostate and reducing the prostate tone and relieving the bladder outlet obstruction. The clinical effects of alpha-1 blockers is between hours to days, and it does not affect the prostate size. The well-documented side effect of alpha-1 blockers, which consists of dizziness, orthostatic hypotension, intraoperative floppy iris syndromes, and ejaculatory dysfunction. The examples of alpha-1 blocker, which consists of a doxazosine, terazosin, alphazosine, tamsulosin, and silodosin. The alpha-1 blocker is used as a first-line treatment due to its immediate and fast acting. Next is about 5-alpha reductase inhibitor, or also known as a 5-ARI. Mechanism of action for 5-ARI is inhibit 5-alpha reductase enzyme that lead to reduced conversions of dihydrotestosterone from a testosterone. Clinical effect in comparison with the 5-alpha blocker. 5-alpha reductase inhibitor is slightly long, in which about 6 months for its effect to manifest. It reduces the prostate size by about 30%, and the well-documented side effect is reduced libido, erectile dysfunctions, retrograde ejaculation, and decreased semen volume. Example of 5-alpha reductase inhibitor consists of dutasteride and finasteride. Alpha reductase inhibitor is well documented to reduce the risk of AUR and the need for surgery. In terms of practical consideration, 5-ARI is always prescribed to a patient who has a moderate to severe LUTS or the prostate more than 40 cc and a PSA level of more than 1.4 nanogram. As we have discussed before, it requires about 6 months for its clinical effects to manifest, hence it should not be suitable for short-term use. Let's talk about the combination therapy. What it means by the combination therapy. The combination therapy consists of alpha-1 blocker together with a 5-alpha reductase inhibitor. The rationale of combining these two medications is because the alpha-1 blocker effects is fast, in which within hours or days, whereas the 5-alpha reductase inhibitor needs several months. Two well-documented studies about this combination therapy, which consists of MTOPS and COMBAT study, have shown that the combination therapy is superior to monotherapy in terms of better control of symptoms and flow rate and reducing the risk of AUR or need for surgery. But on the other hand, the combination therapy is well known of is associated with higher rates of adverse event comparison to a monotherapy. Let's talk about phytotherapy and its role in management of BPE. Before we talk about its role, let's discuss about what it consists of and what is defined as the phytotherapy. Phytotherapy is defined as the use of plant-derived medications in the treatments and prevention of the disease. It can be a herbal drug preparations that are made of roots, pollens, or also fruits. The active compounds that are consist in the phytotherapy can be a phytosterol, fatty acid, or lectins. It has several characteristics, examples as anti-inflammatory, anti-androgenic, estrogenic effect, and so on. The extract of the same plant produced by different companies do not necessarily have the same biological or clinical effect in comparison between one and another. Let's discuss about saw palmetto, as this is one of the common herbal drugs that was prescribed to a patient with a BPE. Based on the Herbal Medicine Product Committee, which is under European Medicines Agency, the use of saw palmetto has its effect in terms of reducing the actions of male sex hormones such as testosterone and its anti-inflammatory effect. Saw palmetto is extract from the fruit of plants called Serena repens. The preparations can be divided into two in which the plant extract into a solvent, whether it is hexane or ethanol. The HMPC mentioned that it can be used to treat the symptoms of benign prostatic hyperplasia based on the evidence of its traditional use, and there is no proper clinical trial up to this point. The side effect of using of saw palmetto is known to have GI tract disturbances and also headache. A study was done, a systematic review to see whether the saw palmetto treatment of benign prostatic hyperplasia. They are divided into 4 criteria, and the first criteria they have found that the result is saw palmetto was not superior to placebo in improving of IPSS urinary symptom score and comparison into other medication. Next, for nocturnal or nocturia, the saw palmetto was significantly better than placebo but was not superior to a finasteride. In terms of peak urinary flow, saw palmetto was not superior to placebo at that period of time. And last but not least, comparing the prostate size at the end point of the study, there was no significant difference between the saw palmetto and the placebo. In conclusion, the authors mentions that the saw palmetto was no more effective than placebo for treatments of urinary symptoms consistent with BPH. Let's move on to the next issue of how should I monitor them in my own clinic. The follow-up for a BPE patient can be done up to a 6-monthly period. In 6-monthly period during a clinical appointments, we can assess the patient's symptoms based on the IPSS score questionnaire. One can also take a PSA level during that period of time to actually determine whether there is a significant increase in comparison to the previous level. Ultrasound KUB can be done to detect the amounts of volumes of post-voiding residual urine and to comparisons with the previous measurements before. A doctor can also review the medication and whether got any side effect developed during the periods of treatment. And if there is any features suggestive of disease progression, it is always best to refer to urologist as soon as possible. Last but not least, let us discuss about an issue of when should I refer a patient with BPE under my follow-up to a urology center. Referral to urology centers is necessary when there is a criteria that suggests this patient in the progressions of disease. What are the criteria? The criteria as mentioned in the slide, which consists of worsening of lewd symptoms based on the IPSS score when the patient is already started on medical treatment. Next is high serum PSA level or urinary retention. The patient develop a gross hematuria during a follow-up, or there is a presence of bladder stone. Patient have complications of recurrent UTI or renal insufficiency secondary to a bladder outlet obstruction or progressions of disease as mentioned before. When these criteria presents, it is always best to refer the patient to a urologist for further assessment. Ladies and gentlemen, in conclusion, BPE is one of the common cause of male lewd symptoms, especially in case of middle-aged and elderly men. Treating a mild or uncomplicated BPE is possible at the GP or primary healthcare level. The protocol for follow-up and diagnosis is not complicated and easy to follow. The saw palmetto can be used for BPH, but bear in mind that up to this point there is no proper clinical trial. And last but not least, if there is a criteria that's suggestive of disease progression, it is always best to refer this patient to urologist immediately for further assessment. With that, thank you.
All right. Thank you, Mr. Fairusha, for the extensive explanation on benign prostatic enlargement as well as the role of phytotherapy. So I think we should go to the Q&A because we have limited time frame. So the first question is, can we treat benign prostatic hyperplasia at primary care settings, or do we need to refer for further evaluation by the urology?
Okay, thank you for the question, Dr. Dexman. I think I've explained in my presentation that treating of BPE is possible to do it at the level of primary care or GP. Why is it so? Because you can save a lot of time, save a lot of energy, and save cost when the patient came for similar follow-up for other disease. Example, they came for diabetes, hypertension, and most of the time that this patient have a stable or uncomplicated LUTS, uncomplicated BPE, they can just be monitored or treated with just a simple medication. So my take from this is actually is possible, and it is always, if there is any progression of disease or suspicious of any complication, one can always refer to a urologist for further assessment.
Yes, I think that is our majority of the patients that we see in our clinic, right? Benign prostatic hyperplasia or enlargement. So the next question will be, is PSA a mandatory test that we should do before starting treatment for benign prostatic hyperplasia?
Okay, all right. Thank you for the question. I think this question also I've addressed in my slide. That is actually doing a PSA will have a baseline of we can actually monitor or detect whether there got any progression of disease, predict the progression of disease, or suspicious of prostate cancer. So to say that for nowadays that I believe most of the clinic, most of the GP can perform a PSA test that was sent to other laboratory, or in terms of primary healthcare, that is possible to do a PSA. So if it's available, then I suggest or I advise to actually take a PSA to have a baseline and to monitor it subsequently for your during the treatment of PPE patient.
All right. Should we take PSA for all the patients?
Okay, so there is actually a controversy about a PSA, monitoring a PSA test. So usually a PSA you take if the age of a gentleman is around 45 and 75, and any suspicious of prostate cancer. So you do want to take a PSA level to have a baseline. And the monitoring, if actually there's no risk or low risk for prostate cancer, you can actually monitor it about in the guideline mentioned in 2 years' time, and to repeat it after the 2 years. But again, this is subject to based on what do we call assessment to the patient.
Okay, all right. So I think the next question will be, is there any role for uroflow study in patient with LUTS or benign prostatic hyperplasia?
Yeah, good question. So of course, there is actually a role of uroflow study, but this is actually, you have to understand that uroflow is not easily accessible or available in terms of GP level and primary health care. So the aim of this talk is actually to help or to explain about how the GP or primary health care doctors can actually monitor a BPE patient and when to refer when necessary or when is required. So of course, the question of whether it is actually a role to proceed with a uroflow test, yes, the answer is yes. So that because uroflow test will tell you the disease progression, number one, and whether the treatment has resolved or the treatment has improved after started with the medications. So is it available, if it's accessible to a patient, then of course you can do a uroflow study.
Okay, all right. So the next question will be, what is the PSA level that we need to refer to a urologist if initially there is probably a raise of the PSA slightly more than 4, subsequently it is 2 or 3? When should we refer and when should we monitor in the GP settings? Okay,
so this is quite a common condition that we have, a patient that was monitored with the PSA. So if he thinks that PSA is double or PSA is increasing in trend, so it's always advisable. And if the patient have a risk factor to develop a prostate cancer, examples during a DRE or prostate size is increased, or the patient a family history of prostate cancer, you can always refer this patient to a urology assessment to rule out further about prostate cancer.
So I think we will take the last question since we also have limited time frame. I think we will try to answer all the questions in the chat box later on. So last question would be, can we stop medication treatment once the symptoms and PS level has normalized?
Okay, so thank you for the question. So most of the BPE patient, the symptoms is controlled, especially for moderate and severe. The symptoms is well controlled because the patient is started with the medications and the patient is already on the treatment. So most of the time, if we actually stop the medication, the symptoms or worsening of the progression of the disease return back again. So it is always advisable to continue the medication. So if in terms of mild IPSS, or there's actually a mild symptoms of BPE, if the symptom is getting better and based on patient judgment, sometimes you can actually stop the medication, observe and see whether there got any problems or any recurrence in the future. So if it's recurrent back again, it's always advisable to restart the medications and to refer to urologists for further assessment.
Okay, all right. I think now we have this 15 minutes talk break, morning break. Then we will continue our plenary number 2 at 10:15. We will try to answer all the questions in the Q&A chat box. I think we thank you, everyone. We'll get back to you later. Thank you. Thank you, Mr. Fairuz.
Assalamualaikum, bos.
All right. Hi, good morning, everyone. So I'm Desmond here. So we are back to plenary number 2. And the next topic will be on shedding light on erectile dysfunction. It will be given by Mr. Chai Chuan, who is our consultant urologist. He just came back from the UK under training for andrology. Please welcome Mr. Chai.
A very good morning to my fellow general practitioner colleagues, and thank you very much for your attendance in this general practitioner webinar organized by University of Malaya. The topic for my talk today is shedding light on erectile dysfunction. What is erectile dysfunction? ED is defined as the inability to obtain or maintain an erection sufficient for penetration and the satisfaction of both sexual partners. The global prevalence of erectile dysfunction is reported to be 52% among men aged 40 to 70 years old. The prevalence of ED in Malaysia is not far apart. In fact, 69% of men less than 80 years old have some degree of erectile dysfunction, with 33% reported as mild ED, 26% moderate, and 10% severe. However, these unfortunate men mainly suffer in silence, as up to 90% of them do not seek treatment for various reasons. Embarrassment, ignorance, and procrastination are major factors. It is also interesting to see that a large number of patients attributed their lack of treatment to not being asked upon by their attending doctor. Unless we are running a specialized men's health clinic, I can understand that ED may sometimes not be included in our routine history taking in our general practitioner setting. Looking at the statistic on major causes of death in Malaysia in 2018, almost all, apart from road traffic accidents, are chronic diseases that are being treated initially at the general practitioner level. Hence, we can probably understand that sometimes our plates are pretty full to routinely look out for ED if our patients did not flag it up in the first place. But I would like to bring to your attention that the penis is actually a health barometer. Studies have shown that ED is an early warning sign of many serious underlying pathologies, such as coronary artery stenosis, diabetic peripheral neuropathy, retinopathy, hypertensive cardiomyopathy. In relation to coronary artery disease, which is the #1 killer for the Malaysian population, there is a strong correlation between erectile dysfunction and cardiovascular disease. In fact, they share almost identical risk factors such as hypertension, hyperlipidemia, diabetes, obesity, lack of physical exercise, cigarette smoking, and poor diet. A famous local urologist recently presented in the National Heart Association of Malaysia conference that a broken heart may be a precursor to a broken heart. This is backed by several high-level evidences which state that a significant proportion of men with erectile dysfunction exhibit early signs of coronary artery disease, and this group may develop more severe CAD than men without ED. The time interval among the onset of ED symptoms and the occurrence of coronary artery disease symptoms and cardiovascular event is estimated at 2 to 3 years. ED is also associated with increased all-cause mortality, primarily due to increased cardiovascular mortality. In association with diabetes mellitus, the incidence of erectile dysfunction is 5 times higher in patients with diabetes mellitus, and more than 35% of patients with diabetes mellitus suffered from erectile dysfunction. Patients with diabetes mellitus are also at risk of developing ED 10 to 15 years earlier. they are usually more serious, more resistant to oral treatment, and have a worse quality of life. Erectile dysfunction is also closely related to depression. In a systematic review of 49 publications involving 169,000 patients, the risk of erectile dysfunction increases by 39% in patients with depression. Furthermore, erectile dysfunction increases the risk of depression by almost twofold. Besides from the mentioned causes and risk factors of cardiovascular disease, metabolic disorders, and psychogenic factors, ED can also be caused by underlying hypogonadism, medications, and previous trauma or pelvic surgery. According to the latest EAU guideline, the diagnosis of erectile dysfunction involves a complete medical sexual history, focused physical examination, and laboratory testing. A complete medical and psychosexual history identifying common causes and reversible factors of erectile dysfunction and patient's psychosocial status, with the adjunct of various validated questionnaires such as the IIEF or EHS scoring. A focused examination includes ruling out signs of hypogonadism, examination of genitalia to exclude anatomical deformities, and ruling out prostatic diseases. It is also important to identify patients' cardiovascular and neurological status. The simplified IIEF-5, which stands for International Index of Erectile Function, is a validated questionnaire for assessing patients' confidence and ability to perform sexual intercourse over the past 6 months. It scores from 5 to 25, and a lower score indicates worse erectile function. Alternatively, the EHS or erection hardness score can be used. It has 1 domain and 4 gradings, and is easier for patients to correlate. A detailed history and physical examination on exercise tolerance are paramount, especially for patients who are at risk. Essentially, sex is a moderate physical activity which equals to walking 1 mile in 20 minutes or briskly climbing 2 flights of stairs in 10 seconds. Cardiac risk stratification is based on the Princeton consensus. Patients who are in the intermediate and high risk category are required to be referred to a cardiologist for assessment and stress tests before initiating erectile dysfunction treatment. The laboratory investigations routinely sent are fasting blood sugar, serum lipids level, and investigation for hypogonadism. Advanced workup on erectile dysfunction is not routinely performed. It is used if there's a diagnostic dilemma or if there's a need to diagnose the type of erectile dysfunction. Intracavernosal injection tests coupled with penile duplex ultrasound can be used for identification of vasculogenic erectile dysfunction, whereas nocturnal penile tumescent test is used to rule out psychogenic ED. Next, we'll be discussing on treating erectile dysfunction.
Treating erectile dysfunction involves increasing patients' awareness of the available treatment strategies while managing the patient and partner's expectation. Traditionally, the treatment strategy for erectile dysfunction involved a step-ladder approach from lifestyle modification to penile implant insertion. However, it is now recommended that all options apart from the implants are to be made available for the patient, and treatment approach should be a shared decision between the patient and treating physician. Lifestyle modification has a huge impact on the quality of erection. The main pillars for lifestyle improvement are regular exercise, healthy diet, stress management, weight reduction, and stop smoking. A meta-analysis involving 28,000 patients showed that smoking 10 cigarettes a day increases the risk of erectile dysfunction by 14%. The erectile dysfunction risk is also increased in being a passive smoker. Patients who quit smoking have improvement in erectile function by 25% in 1 year. It is also important to identify and correct any reversible or modifier risk factors for erectile dysfunction, namely diabetes mellitus, hypertension, hypogonadism, or BPH. In a study involving 12,000 men treated for benign prostatic hypertrophy, 49% are found to have some degree of erectile dysfunction, of which 10% of these had severe ED. A 5-year follow-up on patients who had surgery for BPH showed no significant impact on the worsening of their erectile function. Ever since Viagra introduction in 1991 as a failed drug for treating cardiovascular disease, it revolutionized the treatment of ED. There are currently a variety of PDE5 inhibitor options available. Besides PRN doses, a daily 5 mg dose of tadalafil is currently available as a treatment option for both ED and BPH. It is important to remember that nitrates use is an absolute contraindication for patients on PDE5 inhibitor, as this will result in cGMP accumulation and drastic falls in blood pressure, causing severe hypotension. Based on the half-life of each drug, if a PDE5 inhibitor is taken and the patient develops chest pain, nitroglycerin must be withheld for a total of 24 hours in case of sildenafil and vardenafil, 48 hours in case of tadalafil, and at least 12 hours in case of avanafil. For patients who are on alpha blockers for treatment of BPH, the latest meta-analysis of 19 randomized controlled trials showed that concomitant treatment with alpha blockers and PDE5 inhibitor does not increase the rate of adverse events due to hypotension. The authors suggested that uroselective drugs such as alfuzosin, tamsulosin, and silodosin should be prioritized. Alternatively, patients can opt for a daily dose of tadalafil 5 mg, which is recommended for treatment of both BPH and erectile dysfunction. The use of PDE5 inhibitor is also well documented to assist in the treatment of psychogenic ED. In a study on 90 psychogenic erectile dysfunction patients, both groups of patients receiving either tadalafil 5 mg or de-escalation of PDE5 inhibitor experienced significant improvement in the IIEF scoring. The side effects from PDE5 inhibitor occur in approximately 10 to 15% of patients. The common side effects are headache, flushing, nasal congestion, with more specific side effects such as back pain occurring in patients taking tadalafil. The newer drug avanafil seems to have the lowest side effects profile. However, a 6-month prospective study of 8,047 men showed that the majority of patients were happy and would continue with their PDE5 inhibitor, with a dropout rate of merely 10 to 37%. Failure of treatment is defined as 6 attempts of optimal usage and dosage with a particular drug. The most common causes of failure are inadequate sexual stimulation, inadequate dosage, and inadequate time between taking medication and sexual intercourse. In case of non-responder, there is an option of considering switching to a different PDE5 inhibitor or trial of combination therapy. Prostadil, or Coverjet, is the drug used for intracavernous treatment of erectile dysfunction. Patients are required to learn the self-injection technique, where a fine needle is injected over the lateral aspect of the penile shaft into the corpus cavernosum. The time to erection is approximately 5 to 15 minutes. Due to the fear of needle, this option is seldom preferred and has a high dropout rate of approximately 68% due to a high rate of needle site pain or discomfort. There's a small risk of prolonged erections, priapism, and fibrosis causing Peyronie's disease. The vacuum erection devices provide passive engorgement of the corpus cavernosum together with a constrictor ring at the base of the penis for retention of blood, thus maintaining an erection. Published data has reported a satisfaction rate for penetration to be as high as 90%. However, the ring has to be removed within 30 minutes to avoid the risk of skin necrosis. The dropout rate is 50% and is usually within 3 months, with the main adverse events being pain, inability to ejaculate, petechiae, bruising, or numbness around the area of the constricting ring. Therefore, the vacuum erection device is contraindicated for patients with a bleeding disorder or on anticoagulant therapy. The low-intensity shockwave therapy is currently advocated for treatment of vasculogenic ED. In principle, the shockwave induces microtrauma, leading to angiogenesis and recruiting new stem cells, promoting an increase in perfusion and penile blood flow. However, the overall reported patient satisfaction rate differs greatly from 40 to 80%. This is partly due to heterogeneous data on technical specificity such as generator types and setup as well as treatment protocol. I would also like to share that a recent publication by our colleagues in Penang has shown promising outcomes in improvement in both IIEF and EHS scores using the low-intensity shockwave treatment at 1, 3, and 6 months. The ultimate options for treatment of erectile dysfunction is the penile prosthesis. There are currently 2 types, the semi-rigid malleable or the inflatable type. The inflatable penile prosthesis is usually more preferred among patients as it appears to be more natural. The penile prosthesis may be considered in patients who are not suitable for different pharmacotherapies or prefer a definitive therapy and do not respond to other treatment modalities. It provides the highest satisfaction rates to both the patient and his partner among all treatment modalities for erectile dysfunction. At the same time, has a small risk of mechanical failure, infection, and erosion risk. In conclusion, I would like to highlight that erectile dysfunction has become commoner with increasing age and is seen in up to 60% of men in Malaysia. It is often associated with obesity, high blood pressure, high cholesterol, and diabetes, which are all significant risks to health. ED can also be a precursor to cardiovascular disease. The treatment of erectile dysfunction are mainly lifestyle modification, oral medications, intracavernosal injection, vacuum-assisted devices, low-intensity shockwave therapy, and penile implants. With that, I'd like to thank you for your attention, and I hope you enjoy the talk.
All right. Thank you, Mr. Chai, for this explanation on erectile dysfunction. I think it has been a very great topic, and especially for men out there. So we'll go to the first question. Is too much of masturbation in young age leads to erectile dysfunction in adulthood? What's your take on this, Mr. Chai?
Right. Thank you very much, Desmond. First of all, apologize if there's a reduce in the audio. I think there's some technical difficulties in this. This is a pre-recorded video, hence the voice might be a bit soft on that. So in regards to the very interesting question of too much masturbation in a young age, does it lead to ED? Well, there's no direct correlation which describes erectile dysfunction with the volume or the degree of masturbation. However, there are some papers which describe some patients who were exposed to the amount of pornography, which they would eventually develop the trigger factor being pornography as to an erection, and they might find they have reduced interest significantly to their partners subsequently and they complain of ED. Alternatively, on the long-term factor, patients who were overzealous in masturbating, there's a risk of developing, of course, microtrauma, and this might in long-term develop fibrosis and scar formation, which might lead to Peyronie's disease, and this might cause anatomical abnormalities and subsequently might lead to difficulties in penetrative intercourse.
All right. So I would say that probably those are under the psychogenic erectile dysfunction, maybe?
Yeah, as well as Peyronie's disease if it's developed. Yeah.
Okay. All right. So I think the next question is, when can we advise patients to resume sexual activity after a myocardial infarction?
That's a very good question. So in our guidelines, the way we practice is that we will always refer back to the Princeton consensus. There's a table which divides the patient into low risk, intermediate risk, and high risk groups of patients when we are advising patients to resume sexual activity post myocardial infarction. So it's the important take-home message is at the intermediate risk column. The patients who develop recent MI at 2 to 8 weeks is classified as intermediate risk. So any patients less than 8 weeks post myocardial infarction is we deem not safe to resume their sexual intercourse. For those beyond 8 weeks, if they are not symptomatic and they are classified under the low risk group, we can gradually reintroduce sexual activity.
Okay, all right. So I think that question is a very interesting question. So what's the treatment of erectile dysfunction after robotic RP, prostatectomy?
Right. So this again is a very good question. Yeah. So low intensity shockwave therapy for erectile function has been described for a very long time now. It has been described for the past couple of years. However, recently, regarding penile rehabilitation on patient post robotic prostatectomy has been newly introduced and is in the pipeline. Right now, we don't have any strong and specific data, but so far the results has been promising. And then, in fact, we are hoping to try to kickstart this service soon and hope to have a collaboration with UPM, who has started this study.
All right. I think the main thing is that whether this is resist sparing, non-resist sparing, and things like this.
Yes, of course. If it's resist sparing, of course, this group of patients will be introduced to the penile rehabilitation group. But if it's non-nerve sparing, so the likelihood of success with rehabilitation will be even lower.
Okay. So I think another question is that does all the patients need blood test, especially testosterone, before we start to initiate this PDE5 inhibitor?
Yes, definitely, because we need to identify the reversible cause, and hypogonadism is one of the reversible cause of erectile dysfunction. And then the studies have shown that by treating reversible cause such as hypogonadism, there is a high chance of treatment or reverse erectile dysfunction.
All right, Mr. Chai. I think that is the last question. Thank you very much for your explanation on this topic. So I think we will go to the next topic. Thank you, Mr. Chai.
Thank you very much.
Okay. So the next topic will be on nights of disruption, nocturia. It will be given by Mr. Ahmad Nazran, who is our consultant urologist. He is our current head of urology unit in PPUM. We welcome Mr. Ahmad.
Morning, everyone. I'm Ahmad Nazwan, one of the urologists in University Malaya Medical Center. Once again, as head of division, would like to thank everyone for taking their time from a Sunday morning to come and learn together on this virtual urology webinar. So, the topic I'm going to cover is nights of disruption, nocturia. Okay, so we're going to go through definitions and then why we do or do not get nocturia, what the potential underlying causes, how we work up the patient, and of course, how we manage them. Okay, so just going to go through a bit. So, I think the first one was quite obvious. So, the first one, 60-year-old man who wakes up twice at night. I think we all agree that that is nocturia. Okay, what about this one? So, 50-year-old woman, she works the night shift, so she always sleeps in the daytime. So if she sleeps during the daytime and wakes up to pee at that time, so is that nocturia? Okay, so the answer is yes. So that's why we say it's not just at night; it can also be during the day. So nocturia by the International Continence Society is the number of times an individual passes urine during the main sleep period, okay, whether that is a daytime or nighttime. And having woken to pass urine for the first time, each urination must be followed by sleep or at least the intention to sleep. Okay. Another important definition that we're going to talk about quite a few times during this talk is nocturnal polyuria. This means that passing large volumes of urine during the main sleep period. Okay. For younger patients, less than 65 years old, this is 20%. For older patients, it's 1/3, 33%. Alternatively, you can also count the amount of urine production per hour of sleep. Okay, more than 90 cc is nocturnal polyuria. Okay, won't focus so much on this, but this is more for like pediatric when nocturnal enuresis, which is basically bedwetting at night. And also have to mention, because particularly some of our patients are diabetics, you can have a global polyuria. That means they don't actually just pass a lot of urine at night, but actually throughout the day. And the definition is more than 40 cc of urine over 24 hours. Okay, so why are we bothering to talk about nocturia in the first place? Okay, so first, I mean, most of us feel that nocturia, related to PPH is a problem of old men. So actually, it's not. So if you can see, this is a study by Weiss et al. Done in the States. Even those young patients, 20 to 4-year-old, show that up to 1/3 of them have nocturia more at least once, okay, throughout the day. So it's something, although definitely it's more common in the elderly population, but it's also not uncommon in the younger population. Okay, this is a study done by us in Malaysia. So you can see that even at the young age group of less than 30 years old, the percentage of patients with at least one nocturia is half. Okay, and when it comes to 31 to 40 years old, even up to 2/3 have nocturia. Of course, this includes all number of void, and the higher the number of void, the prevalence decreases, but it's still a significant percentage of people. And why we bother is because nocturia does cause a lot of bother. So you can see here amongst patients with men with lower urinary tract symptoms, you can find that those who have nocturia have a significantly worse quality of life. Okay, and why is partly because when you have nocturia, particularly with 2 or more voiding, you can see that the sleep quality is significantly worse, okay, compared to zero time waking up to pass urine and 2 or more. Okay, so the effect on sleep is not, obviously you don't like. So why we don't like lack of sleep? One, it affects how we function. I mean, like now, if you don't sleep because you're watching Champions League or what, generally you feel you'll be in a bad mood. It's very difficult sometimes to to think because you're too tired, and this in the end is to reduce performance at work. But actually, there have been studies to show that poor sleep is not only an effect on your daily function, but can potentially have long-term effects on health. So these are listed here, and we'll go through a few of them. Okay, so this is a systematic review. Okay, bear in mind most are retrospective study, but it's a relatively strong paper that show that those with nocturia, and just one time, didn't say have to be 2 times, have an increased risk of overall mortality. Okay. And this paper from the US show that the overall cost to the country because of loss of work from tiredness on nocturia amounted to 61 billion in a year. So that's quite a massive amount. Okay. And this study from Japan, not too long ago, 2010, showed that those who have nocturia have a increased risk of fractures, not just fall related, because sometimes they're too tired, too sleepy, they fall down, but of all fractures. And this again, the survey done by us in Malaysia, and found that a lot of patients, as suspected, complain of fatigue, but they also complain of other symptoms such as bad mood, depression, forgetfulness, lack of motivation, and also some mention about lack of sex drive. Okay. Myth number 2. So it's okay to have just one time of nocturia. Okay, it's accepted, but actually not true. So you can see from this survey that for those who have only one nocturia, there's still a proportion that found it extremely bothersome. Okay, almost 5%, and 25% found it to be moderately bothersome. Okay, so you cannot say that it's only important if they have 2 or more passage urine at night. Conversely, you can see there are some patients who have 3 or more passage of urine at night and find it not bothersome at all. So it does boil down to the patient as well. Okay. So why do most of us not have nocturia? Okay, I hope. Okay, one is that unlike animals, we have a diurnal variation of hormones. Okay, we show that later, and we have an adequate bladder capacity so that we can store urine overnight. And hopefully, most of us drink in moderation and not on any medication that can contribute to nocturia. Okay, so just a bit of a refresher, but this is the renin, angiotensin, aldosterone system. So the effect of ANP, renin, and angiotensin quite important for the fluid status. So if there's some effect on this due to cardiac distension from heart failure or by any cause of edema, can lead to increased diuresis and passage of urine. Okay. Another important component is the ADH system. So this works to store water if your body is dehydrated. Okay, and you'll see this has implications for management later as well. Okay, as mentioned earlier, you can see in those patients with nocturia, usually you should have increased ADH secretion at night because this will prevent you passing urine at night. But for those with nocturia, you can see they are significantly lower. Another myth is that if any man comes in with nocturia, it's usually benign prostatic hyperplasia. Okay, actually not true. So you can see this is a paper done by Jung in Malaysia and found that in 85% of patients that are unresponsive to alpha blocker treatment, they actually had nocturnal polyuria. You can see quite a significant percentage. Because there are so many other causes of nocturia, okay? It's not just BPH, you can see. Yeah. How do we classify the causes? Okay, can go one by one. One is global polyuria. That means it's not just nocturia passing a lot at night, but also during the daytime. This can be to high fluid intake, untreated diabetes mellitus, diabetes insipidus, and in the pregnant lady, gestational diabetes. Okay. Otherwise, as I mentioned, nocturnal polyuria, any edema forming states, any sleeping disorders, obstructive sleep apnea, because they can actually, one is that you may purposely, well, sometimes sleeping disorders are voluntary, so you may voluntarily wake up at night to pass urine. But OSA in itself, because of the effect on atrial natriuretic peptide, will also cause nocturnal polyuria. Certain drugs, we'll go through a bit more later, okay, and drinking too much fluid before bedtime, and also certain diseases like Parkinson's can also cause nocturnal polyuria and CKD itself. Okay, as mentioned, bladder capacity, if it's reduced, are expected also cause you nocturia because you can't store the urine long enough. So, example of causes are listed below, BPH, OAB, any infection, interstitial cystitis, or sometimes malignancy as well. Okay, and sometimes, as mentioned, all this can be multifactorial, not just one. Okay, how do you assess somebody with nocturia? So, like any patient, you always start with the history and examination. So, you always start with the lower urinary tract symptoms, but you also need to find out what fluid they consume and types of fluid, including caffeine, alcohol. Okay, sleep habits, as I mentioned, because these are important for if you want to talk about sleep hygiene and sleep disorders. Medication, let's say we go through, not to mention about OSA symptoms, fatigue in the daytime, snoring at night, stopping of breathing at night, as explained by the partner, or this may point you towards OSA. If necessary, then you do the questionnaires. The most common one used is stop bang. Okay, and you have to take a past medical history, particularly for diseases, neurological diseases, diabetes, because they can contribute, and any previous history of surgery, especially for the lower urinary tract. Okay, recommended, we should do avoiding diary. Okay, at least a urine FME, and if the facility is available, you can check the post-flight residual urine measurement in case there's a bladder outlet obstruction. You can use certain questionnaires which will show, okay, and the rest depend on what is your suspicion. So you may want to do urine culture, if you're thinking neurogenic bladder urodynamics test, you worry about BPH, prostate cancer, PSA, and of course if you're thinking about diabetes insipidus, diabetes mellitus, you need to do the relevant investigations. Okay. Medications that can cause, okay, there are a lot of methods. One is medications that cause diuresis, as expected. Anything that can cause edema, okay, anything with central nervous system effect, because they can affect the pituitary or cause insomnia, and anything that can precipitate lower urinary tract symptoms. Okay. As mentioned, very useful in assessment of nocturia, particularly as you need to calculate things like global polyuria and nocturnal polyuria. It's a bladder diary. So it's something that we normally give the patient to do themselves, and you have to do it over at least 3 days. So from the time they wake up in the morning to the time they wake up the next morning, you write what they drink, what they eat. Each time they pass urine, they need to use a simple measuring jug and measure, and also inform if there are any urgency, leakage, and what were they doing at the time if there was a leakage. Were they coughing, or were they doing some exercise? So as mentioned, there are some questionnaires you can use. So this is a Tango screening questionnaire for nocturia, and it's quite nice because it can help to point to you what is the underlying problem. Okay, and if you want to check about quality of life, because I mentioned it's quite important in nocturia, this is a ICIQ nocturia questionnaire. Okay, which can get available online. Okay. So talking about management, so what I want to highlight here is that the management of nocturia is multimodal. Okay, so of course, most important people is you, the GP, but depends on what is the underlying problem. You need a lot of different people involved. For example, if you think it's a fluid problem or a bladder problem, then of course there are certain management you can do, such as restricting fluid, reducing salt, protein intake, restricting caffeine, alcohol. Can in higher level you can go into pelvic floor muscle training, medications for LUTS, and worst case scenario sometimes bladder outlet obstruction. So need to involve the urology team for that. If you think it's related to some form of cardiovascular disease causing edema, then again management by the cardiologist needs to be involved. Okay. And those for where there's problem with obesity, because obesity itself is a risk factor for nocturia, partly because of the OSA, or because of diabetes, then you actually need to involve the endocrinologist and dietitian in these patients. And for sleep-related disorders, if it's OSA, you may involve the respiratory team to get the CPAP machine, and you may need to involve a sleep specialist. So mentioned quite a bit here, but it's not just about, of course, one intervention is about, lifestyle management. Okay, simple things, don't drink before you sleep. If you're going to take a diuretic, take it earlier. For those with edema, wear compression stockings, and of course, losing weight. And as mentioned, you need to treat the underlying condition. Okay. We mentioned about sleep hygiene. So these are just some good sleep practices. So, to time your sleep well, make sure that, you don't nap earlier in the daytime so that you sleep well, and then you can do things to try to make it easier for you to sleep. Having a relaxation routine, taking a warm bath, or taking a light snack. All this can help with sleep hygiene. And of course, avoiding things like caffeine, smoking, which can make it more difficult for you to sleep. Okay, medication. Okay, sometimes we can try diuretic. As you say, you take the diuretic earlier in the afternoon, so that hopefully by reducing the overall fluid in the body, that you pass urine less during the night. But side effects can be quite significant. If there's an underlying overactive bladder, then you can use anticholinergic and thiamine at night so that you reduce the symptoms at night. But again, anticholinergic side effects can be quite significant, and they are conjugated with acute angle closure glaucoma. Okay, so the main medication that we use for nocturia, in particular nocturnal polyuria, is ADH analog like desmopressin. The good thing, there's a recent preparation sublingual, so that means that you don't have to take it with water. You just put it under the mouth and then under the tongue, and it automatically absorbs. Okay, and the main aim is to supplement the reduced ADH secretion at night. Okay, the main thing that we are worried about in these patients is of course hyponatremia. Okay. You can see this is the Octopus trial, the female on the left side and the male on the right side. So main thing you can see there is a good clinical response of desmopressin in nocturia. Okay, quite significant difference. Okay, and this effect is not short term, as it shows that there is a long term response. And if you stop the treatment, unfortunately, you get a recurrence of the symptoms. Okay. And basically, Noctopus was actually 4 trials combined, but just for the benefit of time, telling this. So basically, it decreased the number of nocturnal voids, increased duration of first hour of undisturbed sleep, and safety profile actually they found to be quite similar to placebo. And hyponatremia in most cases were actually transient, and in the initial part of the study where they were actually trying to titrate the medication. Okay, and most of them were not clinically significant. Only 2% had sodium less than 125. But they do advise to be more cautious in those who are more than 65 years old. Okay. So if you give this medication, how should you monitor for hyponatremia? So in particular, those in the elderly, you need to be very careful. But what I advise would be serum sodium at the baseline, 3 days after initiation, 1 month after, and if you're doing any changes in the dose. Okay, always start at the lower dose first. And the other important thing, patient have to be very compliant. So 1 hour before you take the medication, you shouldn't drink anything. And ideally, you should not drink anything until the next morning. Because if you drink while this medication is on board, the risk of hyponatremia is quite high. Okay, as mentioned, most of the time the sodium levels are not too low. And if you stop the medication or reduce the medication, it resolves quite fast. So you need to advise patient what to look out for. Nausea, headache, muscle weakness, all these are early signs of hyponatremia, for which they should go and seek medical help. Okay. So in summary, despite the higher prevalence of nocturia among the elderly, it actually can affect not just men, but also the women of the younger population. Okay, and nocturia is not just a disease for the elderly or BPH. It can be a lot of other causes, and assessment is vital to identify what's the cause so that we can put the correct treatment. Okay. And why we're interested is because nocturia can cause problem with sleep, and this can affect not just daily life but potential long-term effect on health. Okay, and management is not just a single person; it's multidisciplinary, involving lifestyle modifications, also treatment of any underlying cause. Okay. Okay, so if anyone needs any further support, you can actually go to this website here or contact the email. A lot of info and resources regarding nocturia, but important thing for us, we like free stuff. You can actually request for free voiding diaries and bags to be delivered. Okay, with that, I thank you.
All right. Thank you, Mr. Ahmad, on this topic regarding nocturia. So it is a very good topic, and I think that initially we all thought that everything is about prostate here. So I think here you have enlightened us regarding all the other possible causes. We'll go to our first question. When do we decide we can use desmopressin for nocturia if other causes of nocturia are not identified?
Thank you for the question. So I think if you have a lot of other things that you can treat, for simple things, UTI, prostate, then you have to, as all things, is a bit of a shared decision making. So you need to assess your patient. Okay. Number one, as mentioned, for those in the elderly, you need to be a bit careful because the risk of hyponatremia is higher. And you need to check, is the patient also, what's the sodium level of the patient? How compliant is the patient? Okay, because they have to be very compliant. They have to come back for follow-up, and they have to promise, to be very strict, not to actually drink after you're taking the medication. So they cannot forget and then drink. So normally in my practice, I will always talk to the patient and then give all these things, give all this information, and then let them decide whether they want to take or not. Because have to remember, it's not, although of course there are potentially studies about long-term health effect, but none of the studies, as can be said, are very strong. So it's not like, as severe, not like hypertension, if you don't treat, you get heart disease or not. So I think I have to discuss whether they are willing to take the risk of the medication itself or not.
All right. So what is the recommended dosage for desmopressin initiation?
Forgot to add to that one. So after you have done that, so you need to diagnose. Usually we use the minimum mainly for nocturnal polyuria. So you need to do the bladder diary, found the more than 33% or more 20%, then proceed. So next question, thanks for the question. So normally you start on the lowest dose. That's the answer. So for the previous preparation, 0.1. Okay, but for now the latest sublingual preparation is 60 microgram. So always start the lowest dose and see how they respond. If they find that the response is good, then very good. If not, then you can go to the next higher dose. But of course, you have to remember that the higher the dose, the more chance of side effect, particularly hyponatremia.
All right. Is there any benefits of desmopressin usage for uncontrolled diabetes mellitus patient?
I think normally, thanks for the question. I think normally for my practice, I will always want to try to treat the underlying cause first, if possible, and treatment of uncontrolled diabetes mellitus has benefits, not just improving the nocturia, but also reducing risk of heart problem, kidney problem, or the diabetic foot like that. So I think I would actually focus on that first. If after the diabetes is well controlled, then we can revisit that question.
So I think it goes down to the basic, what is the reason why patients have nocturia first, then we treat based on that, and after that we evaluate further, right?
Yep.
All right. We go to the next question. You mentioned that the next question is regards of desmopressins in females above 65 years old. Is there any concern regarding female gender?
They found, thanks for the question. So they did find that for female, there's a bit higher risk of the hyponatremia. Okay. So, I mean, it's not a contraindication, but particularly those more than 65 and female, you need to be quite careful. So normally as my practice before, you start, you need the sodium level. 3 days, I will do again. And then normally, if they're okay, then I'll do again in 1 month.
I see. If the symptoms has improved after a few months' time, will you stop the medication?
Okay, that's an interesting question. Okay, so you can see, because all this is basically symptom control. So you can actually discuss with the patient if they want to try, they can stop it. Okay, because I said this, and although there are some study, but there's no strong evidence of very detailed effect. So if the patient wants to try, I don't see the why you cannot. But as you can see from the study, the Octopus study, when they stopped the medication, the nocturia did. But as I said, sometimes all this may also be other things. So possibly, maybe patient after you started medication lost weight, exercise more, diabetes better control. Maybe in those kind of situation, it's not wrong to try to stop it.
All right. So another question from the floor. If the patient is not bothered by nocturnal polyuria, do you still proceed to do diagnostic workup for them?
Okay. Thank you for the question. So I think I will still do, because sometimes this can be the first presentation of other problems. For example, what you don't want to miss is something like prostate cancer, bladder cancer. So at least the initial investigation of the urine FME, bladder diary, because those are non-invasive, I will proceed.
All right. I think we have the last question here. It will be, how safe is this desmopressin for long-term use?
Currently, from my literature review, I didn't know of any potential long-term side effect. But the thing is that you have to keep an eye on the patient, particularly if you decide to make any dose changes, or if there's any change of any concurrent medication like diuretics, which may affect sodium level, then you may need to monitor the sodium a bit more closely. That's why I have not noted any study of deleterious long-term side effects.
All right. Sorry, I think we still have another question that came in since we have time. This question will be on how much fluid should we limit to rule out fluid intake causes for nocturia in elderly patients?
I think it's not so much about how much you should limit or not. And this is one of the nice thing about the bladder diary. So you can see, they take this, they take the teh tarik at 7 p.m. And then you see 9 p.m. we start peeing a lot. So it's not so much about the intake, but as you want to see how you can change their pattern of drinking. Not so much maybe the time, because I mean, as what Dr. Jeffrey mentioned earlier, you do need fluid. You cannot say, you don't want to pee you, so pass you in night, so you don't take off. But more about changing the pattern of how they pass you, how they take their fluids. Take more during the day, don't take after dinner. If you want to take tea, take in the morning.
Yeah, I think that's a very good answer. Anyway, the next question will be, what about nocturnal enuresis in children? When do we start on desmopressin?
I think that one, unfortunately, you had a lecture yesterday, but was actually targeted to the thing. So I think nocturnal enuresis is not such a simple thing to just start like that. But these are particularly, I'm assuming you're talking about kids, right?
Yes.
So you need to talk whether is it monosymptomatic, is it primary nocturnal enuresis, is it secondary nocturnal enuresis? So there's a lot more workup that I think is outside the scope of my topic lah. Okay, so but basically you need to assess the patient carefully, see particularly not any other urinary tract symptoms or not any other bowel symptoms which can be concurrent, or then any suspicion of any other urological abnormalities. Whether they say any behavior habit. Some people have dysfunctional voiding or not that you need to address. And of course, the other thing you need to think about is whether this could be a red flag, a sign of abuse, particularly for secondary nocturnal enuresis. And once you have done all that and you try, of course, simple things, star chart, alarms, you try all those methods, and then you find that patients still have a significant nocturnal enuresis, then you can discuss with the parents and see whether you want to try it. But there's a lot of other workup to do, not as straightforward as a doctor.
All right. Last question. I promise you, this will be the last question. And Is there concern of use in medication desmopressin in CKD patients?
Thanks for the question. It's a good question. But I mean, CKD, as we know, they have a tendency to have a bit of a low to normal sodium level to begin with. Okay, so you need to monitor closely regarding the sodium level.
All right.
That would be my statement.
Okay, I think the rest of the questions we will answer in the chat box. Thank you, Mr. Ahmad. Thank you for your extensive explanation on all the questions.
Thank you.
All right. So next, we will go to the next topic on exploring the challenges in overactive bladder syndrome. It will be given by Mr. Yo Wei Xian, who is our consultant urologist in PPUM. We'll welcome Mr. Yo.
Good morning, everyone. Today, I have the pleasure of speaking on the topic of exploring the challenges in overactive bladder syndrome. And I shall strive to be concise, as I do not want to stand in between everyone and their lunches. A brief outline for the lecture would cover what is overactive bladder, some basic definition of terminology as defined by the International Continence Society or ICS, common presentations of overactive bladder in primary care, the general and overall approach to a patient with overactive bladder, as well as some take-home messages. Lower urinary tract symptoms can be divided largely into voiding symptoms, storage symptoms, as well as post-micturition symptoms. Overactive bladder is a subset of storage symptoms in the presentation of lower urinary tract symptoms, and it can cover a wide spectrum, from the occasional urgency all the way up to severe urgency with pain and urinary incontinence. So, what is overactive bladder? It is a clinical diagnosis referring to urinary urgency with or without urge urinary incontinence, and can often be accompanied by either frequency, which is defined loosely as 8 or more times per day, or nocturia. All this in the absence of infection or any other obvious pathology. It can further be classified to overactive bladder wet, when the overactive bladder is associated with urinary incontinence, versus overactive bladder dry, when there is no urinary incontinence. Overactive bladder usually has a chronic cause and can have debilitating effects on the patient's quality of life. Now, allow me to elucidate and cover some recurring terminology that will be mentioned in this presentation. Urgency is defined by the International Continence Society as a sudden, strong desire to void that is difficult to defer, while urge urinary incontinence is defined as involuntary urinary leakage accompanied or immediately preceded by the sensation of urgency. There are, however, other types of urinary incontinence, such as stress urinary incontinence, which is defined as involuntary leakage on effort or exertion, or on sneezing or coughing. Now bear in mind that some patients may actually have mixed urinary incontinence, as in they have both urgency urinary incontinence as well as stress urinary incontinence. Based on the epidemiology of incontinence study, the EPIC study, which is actually a cross-sectional telephone survey of adults aged 18 years and older, performed in Canada, Germany, Italy, Sweden, and the UK, and accruing more than 19,000 respondents, overactive bladder was found to have a prevalence of 11.8%, with overactive bladder accounting for 10.8% of male respondents and 12.8% in female respondents. Other studies reported prevalence of up to 40%, and the prevalence rates generally increases with age. Another study done in the East Asian population of China, Taiwan, and South Korea quoted a prevalence of 20.8%, with it being slightly more prevalent in women. Again, overactive bladder prevalence increased significantly with increasing age, from 10.8% in patients aged 40 to 44, up to 27.9%, which is more than double in those aged 60 years and above. So this translates to 1 in 5 patients that is encountered potentially in primary care in that age group, and they may actually have overactive bladder syndrome. Another study by Christopher Chappell found that despite border of symptoms, only 26% of individuals with lower urinary tract symptoms, according to the ICS criteria, were reported that they visited a healthcare professional during the previous 12 months because of urinary symptoms. In other words, only 26% seek out medical care. The symptoms with quite a bit of greater border were nocturia, urgency, and terminal dribbling. So, there is a need for increased patient awareness as well as healthcare provider awareness on the diagnosis and treatment for these lower urinary tract symptoms. Another post hoc analysis done by Lee et al. Showed that lower urinary tract symptoms and increasing OAB severity were both associated with impaired quality of life, leading to reduced workplace productivity as well as an increased tendency towards anxiety and depression. Hence, it is very important to identify patients early and to institute timely and appropriate treatment. So, what are the risk factors for overactive bladder? The risk factors include bladder inflammation, chronic bladder outlet obstruction, for example, benign prostatic obstruction, urethral stricture or urethral stenosis, central nervous system disorders, pregnancy, prior standard vaginal delivery, postmenopausal status in women, older age group, and obesity. However, we notice that by far and large, the commonest risk factor is actually idiopathic. In addition to being bothersome and affecting quality of life for patients, some overactive bladder associated with clinical symptom complexes termed complicated overactive bladder. A patient may be suffering from complicated overactive bladder if, in addition to the overactive bladder symptoms, there are the following characteristics, which is failure to respond adequately to overactive bladder treatment, extremely severe symptoms, patients who are very young, patients who have concomitant hematuria, or patients who have overactive bladder associated with recurrent urinary tract infections, women with severe pelvic organ prolapse defined as grade 3 and above, patients with concomitant fecal incontinence or associated constipation, patients with history of genitourinary cancer, or those with history of pelvic irradiation, patients with other neurological diseases, impaired mobility, or those with poor glycemic control among diabetic patients. These are termed complicated overactive bladder. So how should we then approach overactive bladder in the primary care setting? Of course, first we need to take a thorough history. For example, identifying whether the urgency occurs with coughing, sneezing, lifting exercises, or changes in body position, and also whether consumption of certain food or drinks actually precipitates the symptom. A history of constipation and immobility may also accompany symptoms. Next, we need to assess the severity of the symptoms, right, as well as whether the urgency is associated with any involuntary urinary loss or incontinence. as well as the degree of bother it causes the patient. If incontinence is present, we should inquire how many pads are actually used and whether it is just damped or fully soaked through. Now, any association with voiding symptoms like frequency or nocturia or post-stream should also be elicited. We can also inquire whether there are any other risk factors, for example, a previous obstetric history, taking into account any obstructed delivery or instrumentation during delivery, any previous abdominal or pelvic surgery, any previous radiotherapy, whether there is any concomitant neurological disorders like multiple sclerosis, stroke or Parkinson's disease, or lumbar disc disease. Of course, a history of other genitourinary conditions like urethral stricture, diverticulum, or history of recurrent urinary tract infection or sexually transmitted infection should also be elicited. In addition to that, we can also assess the patient with a validated questionnaire. The International Consultation on Incontinence Questionnaire, or the ICIQ, overactive bladder module, covers 4 domains and is based on patients' recall of events over the preceding 4 weeks. This questionnaire is available online if you Google it, or you could easily scan the QR code attached here, which will take you directly to the PDF of the questionnaire. The patient's fluid consumption in terms of type of liquid, as well as amount, should also be elicited in the history. Other things to review in the history are medications that the patient is currently taking, and whether any of them could be related to the symptoms. Last but not least, do watch out for red flag symptoms, which are pain associated with urgency, hematuria, or the presence of recurrent urinary tract infections associated with the symptoms. In the primary care setting, a physical examination should include a general examination of the abdomen, looking for a palpable bladder, a neurological examination including gait and reflex, perineal sensation, and lower limb function. In men, a prostate examination and the digital rectal examination is also needed to exclude any rectal mass, constipation, as well as to assess the rectal tone. In women, a chaperone pelvic examination should be attempted, looking out for any pelvic organ prolapse, urinary leakages on stress, as well as signs of estrogen deficiency. Also, pay attention to any red flag signs like new onset of neurological deficit, the presence of hematuria, as well as any mass per urethra, a palpable bladder, or in the pelvis. If a patient is clinically suspected of having overactive bladder, the patient should be advised to perform a frequency volume chart, or also what is commonly known as a bladder diary. Now, this is a 24-hour recording of the type of fluid consumed, as well as the volume of the frequency and volume of urine voided, whether it is associated with any urgency episodes, what is the degree of the urgency, as well as whether this led to any incontinent episodes, while taking into consideration amount of urinary loss over a 3-day period. An example of a bladder diary that we use in our daily practice is shown on the right, and this is a snapshot of it. So, what are the investigations that can be sent in the primary care setting? A urinalysis can be performed, looking for presence of infection, hematuria or glycosuria, and if available, a urinary flow rate and a post-void residual can also be performed, although it may not be freely available in the primary care setting. Bear in mind, a voided volume of at least 150 milliliters is needed for adequate interpretation of the flow rate. The photo shown here is a good flow rate because it's done in a patient who has undergone a transurethral resection of the prostate. If indicated, do consider referring patients on for more specialized investigations. This includes a cystoscopy, which is the direct visualization of the bladder using an endoscope, and is performed for patients who are at risk for urethral stricture or bladder cancer. It is usually indicated if the patient has urgency associated with incontinence, if there's a need for invasive intervention, or when empiric therapy has been unsuccessful, or when initial diagnosis is unclear, or when a neurological etiology is suspected. Similarly, if an invasive intervention is being considered, or when there is failed empiric therapy, or when there's unclear diagnosis, or if there's a neurological etiology being suspected, a pressure flow study or urodynamic study can also be performed. Again, this investigation is usually performed in a center with urological services. Sometimes, we may also perform imaging of the upper urinary tract. This can be useful in select cases such as patients with pelvic organ prolapse or those with bedside evidence of high intravesical pressure. Patients with chronically elevated post-void residuals, patients with abnormal creatinine, or in patients whom there is a suspected urethrovaginal fistula. A lower urinary tract imaging like an MRI of the pelvis may be indicated if there is suspicion of urethrodivesticulum or fistula. Also, imaging of the nervous system can be performed if neurological cause is suspected. Next, we move on to the management for overactive bladder in the primary care setting. Usually, we always start with non-invasive management, and the backbone of non-invasive management is lifestyle modification. An analysis of the frequency volume chart of bladder diary may give a hint of the best strategy to advise the patients, but by far and large, patients should be advised to avoid bladder irritants like drinks containing caffeine, alcoholic drinks, or fizzy drinks. Patients should also do time voidings to prevent the bladder from being too full. And modification of timing of fluid intake, for example, avoiding fluids before bed could also be helpful. In addition to that, smoking cessation, as well as weight loss in the overweight or obese patient, could similarly be helpful to alleviate symptoms of overactive bladder. Supervised pelvic floor muscle training accompanied by biofeedback can help patients become more aware of pelvic floor muscles. Studies have shown that health professional directed pelvic floor muscle training is more effective at improving symptoms than self-directed ones, and the more intensive the training regimens, the more successful. However, compliance is often a problem, as more than 50% will stop therapy, and hence periodic reinforcements from a healthcare professional is essential. The pelvic floor muscle training consists of intermittent maximal isometric contraction of the pelvic floor muscles, with each contraction held for 6 to 8 seconds and followed by a brief period of relaxation. A common regimen is a set of 10 contractions 3 times a day. The training should be performed for at least 3 months, as improvements typically appear 6 to 12 weeks after commencement. So allow me to recap. The first line therapy for the treatment of overactive bladder is behavioral therapy with or without pharmacotherapy. However, in the event of persistent bothersome symptoms, pharmacotherapy can be considered. Choices of pharmacotherapy include anticholinergics versus beta-3 agonists, either used alone or in combination. Now, a bit of background. We know that acetylcholine acts on the muscarinic receptors of the bladder smooth muscles, causing involuntary contraction and provoking symptoms of bladder overactivity. Anticholinergic medications target these muscarinic receptors competitively, and about 50% of patients will benefit from medications. The symptoms may improve within a week, but maximal benefit is achieved by 3 months. However, more than 50% of patients actually stop medication within 3 months due to perceived ineffectiveness, cost, or intolerance to medication side effects. So what are the muscarinic receptors then? There's currently 5 known subtypes of muscarinic receptors, denoted M5. The bladder contains M1, M2, and M3, with M2 being more abundant, but M3 being the primary receptor that mediates bladder contraction. Inhibition of the M3 receptor in bladder reduces the detrusor contractions, while inhibition of other muscarinic receptors outside the bladder can cause side effects. For example, in the eyes, inhibition of M3 causes pupillary dilatation and leads to blurring of vision. Inhibition of M3 receptors in the salivary glands leads to reduced saliva secretions, causing dry mouth. And inhibition of M3 in the bowels leads to reduced motility and constipation. Inhibition of M2 in the sinus node of the heart may lead to tachycardia, and inhibition of M1 receptors in the brain can impair cognition and memory. There are many examples of antimuscarinics available on the market, but they are largely divided into tertiary amines, which are more likely to cross the blood-brain barrier and hence more likely to have effects on cognition and memory, as well as quaternary amines, which are unlikely to cross the blood-brain barrier and hence less likely to cause cognitive impairment. Now, examples of tertiary amines are oxybutynine, tolterodine, physotyrosine, derifenacin, solifenacin, hyoscyamin, flavoxate, and dicyclomine, while examples of quaternary amines are trospium and propenthalin. As mentioned earlier, antimuscarinics are associated with quite a few side effects, the commonest of which is dry mouth due to inhibition of the salivary glands. Do note that the oral extended release formulations have lower rates of dry mouth compared to immediate release formulations. Other side effects include constipation, blurred vision, headaches, dizziness, drowsiness, while rarer side effects are tachycardia, urinary retention, cognitive impairment, and impaired perspiration. So, given that up to 50% of patients will discontinue medication due to side effects, how then do we improve compliance? The two common side effects are dry mouth and constipation. Hence, managing these side effects may promote compliance. It is recommended to manage dry mouth with the use of oral lubricants, sipping water, sucking on sugar-free hard candy or chewing on sugar-free gum, and also avoiding alcohol-based mouthwash. Constipation should be managed with adequate but not excessive amounts of fluid, adequate fiber intake, use of stool softeners and laxatives, as well as regular exercise. Now, do bear in mind that there are several contraindications or precautions to starting an antimuscarinic for a patient with overactive bladder. These include patients who are at risk of urinary retention, those with known gastric retention, known intestinal obstruction, or those with uncontrolled narrow-angle glaucoma, or those with myasthenia gravis. Now, although central nervous system side effects are not too common, but it can occur when an anticholinergic passes through the blood-brain barrier into the central nervous system, leading to side effects like somnolence, delirium, and memory impairment. Therefore, consideration should be taken for the number of drugs with anticholinergic effects that the patient is already taking. This is particularly important for patients who are more than 65 years old. And medications with the highest anticholinergic effects are bladder antimuscarinics, antihistamines, as well as antidepressants. So if the patient has a very high anticholinergic burden, then you might want to reconsider starting the patient on antimuscarinics for the overactive bladder. However, in addition to antimuscarinic, an alternative class of medication can be used for the treatment of overactive bladder, and this is the beta-3 adrenoceptor agonist. This class of medication causes smooth muscle relaxation by reducing detrusor sensitivity to calcium and can improve bladder storage without affecting contraction of the bladder. It can be used for patients in whom antimuscarinics are either contraindicated, ineffective, or have unacceptable side effects. However, it also has contraindications, and the contraindications for the use of beta-3 agonists are severe uncontrolled hypertension, defined as a systolic blood pressure of more than 180 and a diastolic blood pressure of more than 110. When lifestyle modification and pharmacotherapy are ineffective, then other options that can be considered are slightly more invasive, and this includes the use of intravesical botulinum toxin injections, neuromodulation, as well as, in worst case scenarios, surgery, either an augmentation type of surgery or surgery for urinary diversion in the very, very refractory overactive bladder patients. Now, these interventions are usually done in a specialized setting by the urologist. So, in the primary care setting, when should the patients be referred on for specialized assessment and management? Patients should be referred when they have complicated overactive bladder, evidenced by the presence of failure to respond to initial treatment, extremely severe symptoms, young age, hematuria, recurrent UTIs, severe pelvic organ prolapse, when OABs are associated with fecal incontinence, constipation, or when patients have history of genitourinary cancer, history of pelvic radiation, or neurological disease. But patients also need to be referred when there is a need for specialized investigations like cystoscopy or urodynamics pressure flow studies. Last but not least, do refer patients when they have red flag signs and symptoms like overactive bladder associated with recurrent urinary tract infection, hematuria, or new onset neurological deficits. Last but not least, I would like to remind my fellow colleagues that overactive bladder can be debilitating with a chronic cause and can severely affect patients' quality of life. Our role as healthcare providers, in addition to providing relief for the symptoms, is to screen for sinister underlying pathology and refer the patients for specialized care if red flag signs and symptoms are present. The mainstay of treatment for overactive bladder is a combination of lifestyle and behavioral therapy, with or without pharmacotherapy. A bladder diary gives good insight to patients' daily fluid intake and voiding habits, and its use can facilitate lifestyle advice and behavioral modifications. And last but not least, when in doubt, do consult your friendly urologist. With that, I would like to thank you for your kind attention and enjoy the rest of the day and your lunch as well. Thank you.
All right. Thank you, Mr. Yeo, for this debunking the myth on overactive bladder. So, first question we'd like to ask Mr. Yeo is that, which medication will you prefer, anti-muscarinic or beta-3 agonist?
Well, I think the choice of medication is very personal. So, but I would like to reiterate that if the patient does have storage symptoms or overactive bladder, the mainstay of treatment is not purely in pharmacotherapy. So please do not forget that lifestyle modification is very important. But if the patient does require pharmacotherapy, then it depends on the patient's requirement and lifestyle. Certainly, antimuscarinics and beta-3 agonists are used similarly in the symptoms of overactive bladder. And I don't think one is actually superior to the other. So the choice would largely depend on the side effects, the potential side effects that the patient might have. In slightly elderly patient, I tend to err more towards beta-3 agonists because of the fear of the cholinergic burden and also worsening of CNS function. But if it's a young patient and the side effects are not too severe, anticholinergics are well established and quite well accepted in those age group.
All right. Will you personally give commonly prescribed lactulose with patients on antimuscarinics?
I'm not too big a fan of pharmacotherapy. So I would advise, as you've seen in my slide, I would advise lifestyle modification first, increasing exercise, reducing weight, increasing fiber intake in the diet. But certainly if it's severe enough, then I would consider, but I would also consider switching or changing to another therapy. Just instead of taking two medications, one to alleviate the side effects of another, perhaps there are alternatives on the market like the beta-3 agonist, which has less constipation according to its drug insert.
Yep, I think, yeah, at least we do have a choice, right? So the next question will be if the symptoms improve after a few months down the line with medication, will you stop the medication and observe the symptoms?
Again, pharmacotherapy has its burden, right? Not just from the pharmacotherapy of it, but also on finance as well. So if the patients are improved on symptoms and they wish to wean off, then I would tell them that it is possible, but to monitor the symptoms. Certainly, it must be done in conjunction with lifestyle modification. So I think the important thing in the primary care setting is to establish that there's no magic bullet to treat the medication. This is not like you're having a pain, you pop a pill and the pain goes away and it's permanent. So it's an ongoing work, right? There are days when symptoms are worse, there are days when symptoms are better. So as long as there's this awareness and the expectation is set straight, then I think weaning the medication according to the severity of the symptom is reasonable.
All right. The next question will be, in Malaysia, is there available OAB treatment like PTNS or sacral neuromodulator to those who fails OAB medication?
There is certainly, but probably you have to refer them on to specialized centers. We certainly do PTNS, we do neuromodulation, right? So there are a lot of other options as well, but sometimes re-exploring the history and the medication chart may give you a clue to see whether you can help them. But for refractory or severe symptoms, then please kindly refer them on so that we can offer more invasive options of treatment.
All right. Next, this is a very interesting question. How do you manage with diabetes patients who are well controlled on SGLT2 inhibitors, which can aggravate concomitant OAB?
Well, thank you for that question. I think that's something that we see quite a lot in clinical practice. So yeah, I mean, my treatment doesn't really change. So I would probably start on lifestyle modification and perhaps consider pharmacotherapy. But the other thing is to see whether there can be an alternative to the glycemic control other than the SGLT2, because that does induce glycosuria and that can be quite an irritant to the bladder.
All right. I think that will be our last question here. I would like to thank the audience for the very good, excellent response. We have more than 400 participants here. All right. Thank you, Mr. Yo. Thank you for your time.
Right.
We will see you.
Thank you, everyone, for the questions. Yep.
At 1
Have a good lunch.
All right. So the next will be on plenary number 3. We have 2 more topics will be given by Mr. Ganesh as well as the Prof. Ong. We'll see you back at 1 o'clock. Thank you. Hi everyone, I believe we already have a good lunch. So here we are back for plenary number 3. My name is Desmond. We will go to the next topic. We still have 2 more topics left. The next topic is on debunking myths surrounding urinary tract infection. It will be given by Mr. Kanesh Kumaran, who is our consultant urologist, UMMC. Please welcome Mr. Kanesh.
A very good afternoon to everyone. I thank the organizing committee, Mr. Jeffrey and his team. And I would like to also state that challenges in life come in many forms. If you're chosen to speak just before lunch or after lunch, I hope everyone could just sit back and digest. Let's talk about UTI. So a disclaimer, urinary tract infections, the infection part of it is mainly an infectious disease lecture. And today I'll be looking into the urological perspective of urinary tract infection. So the basics in urinary tract infection, there is a history, physical examination, always involves a urine dipstick, a microscopy or a culture, and eventually leading up to antibiotics. It sounds like a piece of cake, but now the cake has become more complex. So one of the most common diagnoses in emergency room and outpatient facilities is urinary tract infection. And CDC in 2014 reported up to 40% of patients were misdiagnosed. And why is that so? The overtreatment, overdiagnosis could be the fact that many asymptomatic bacteriuria patients have been tested. Indications may not be appropriate, and often the urine analysis is misread. So oftentimes it is stated that the microscopy is more accurate than the dipstick, but the differences are minimal. The more important aspect here is in the correct clinical context. So any good test in a wrong indication may not prove its efficacy. And there are a lot of catches when it comes to reading a urine analysis, such as contaminated sample. Classical teaching, less than 5 epithelial cells per high power field microscopy would represent an uncontaminated sample. And what does contamination actually means? It may affect the ability to get correct culture, but the accuracy is only affected to some degree. There are also other issues related to looking into a urine analysis, such as not all organisms actually produce nitrites. And we have immunocompromised patients who may not mount the septic response needing to show white cells, as well as there are many other conditions that could mimic a urinary tract infection. So let's briefly run through a common run-of-the-mill scenario. The time now is 7 a.m. in the morning. You are in the final hour before passing over to your colleague, heading back for well-deserved rest. And just to set the mood, we'll change the background. We have patient Pening, who was brought in by family members for confusion and poor oral intake. He's a 78 years old gentleman with past medical history of hypertension, diabetes, mild cognitive impairment, and an enlarged prostate. Medications that he's currently on as shown. So given we are in that golden hour, so we would quickly sign off some bloods, urine, get some imaging, and check his brain with a CT to look for any acute changes. Of course, the microscopy will come out first, and it's negative for nitrite in this patient, and leukocyte was 2+. Quickly, the patient has been referred to urology for complicated urinary tract infection with underlying BPE. But there are so many possibilities that could have been overlooked, such as constipation, which is very common among elderly, change in environment, who knows if the patient was actually institutionalized recently, electrolyte imbalances given that he is on hydrochlorothiazide, SIADH could be induced by hydrochlorothiazide, and the list just goes on. So what does the evidences say? The current evidences say that there is no role in treating asymptomatic bacteriuria in patients, unless in two specific indications, which is if the patient is pregnant, or if the patient is being planned for a urological procedure which breaches the mucosa of the genitourinary tract. These are some of the evidences, but there are many. So, I mean, we were looking into very technical aspects. We were looking into the technical aspects. Let's move on to some lighter areas within urinary tract infection itself. This is two nostalgic pictures of the 20th century. It is showing the iron lung as well, a young boy in an iron lung doing his daily activities. And it was this man that changed the outcome of history. Jonas Salk, the founder of the polio vaccine. And if we understand, polio is a fecal oral transmission, meaning to say it gains entrance through the mucosal surfaces. I think up to date, FDA has approved 5 mucosal vaccines. One is polio, cholera, salmonella. The other 2, I think I need to check back. And when it comes to urinary tract infection, there are also vaccines available. The first one is shown is the Salco-Urovac, which is given in the form of vaginal suppositories as well as parenteral injections. Shows good efficacy. The second one, Uromune, which is sublingual spray, and it's taken for a period of 3 months, and there is booster doses available. The efficacy of this is quite promising. Up till 70-80% of patients are free of a new urinary tract infection episode. The one on your right is Urovaxome. This is an oral preparation taken daily for 3 months, and there is booster doses that are available at 7, 8, and 9 months. And all this are currently in population-based studies, but they are also available in certain parts of Europe. So the only treatment that is effective against recurrent urinary tract infection is antibiotics. We are advocating many lifestyle behavioral modifications, such as taking supplements of probiotics, cranberries, as well as intravaginal suppositories of probiotics. But the only effective one that we really have is antibiotics. And what we must know is antibiotics only work as long as the patient is on them. The moment antibiotics are stopped, the patient might get another episode of urinary tract infection. So this is basically like teaching a man to fish, and this won't give him the ability to sustain as compared to giving him a fish daily. So this is some of the data available with UTI vaccine efficacies. I chose Uromune, and these are prospective studies, and the UTI-free rates are quite good. A wide interval, 33 to 90% over a 9 to 24 months. So what are the issues with vaccine here? So it has promising data, good safety profile, because the contender here is antibiotics, and we are not talking about the side effects, the cost, as well as the resistance that is a big growing concern worldwide. But the disadvantages or the shortcomings are the long-term data are still not available, and the sample sizes used are still relatively small and they are not readily available yet. So when it comes to cranberries, this is actually a booming industry in the health facility. There's a lot of influencers who are now going organic. But what its real efficacy? The indication for recurrent urinary tract infection with cranberry is actually weak. All the studies that have been done are using preparations, lab prepared, and what is available for daily consumption may not translate to what actually happened during that study. So the other issues relating to this, we do not know whether the juice is the best form. The cold pressed juice is the best form. Blended pills still is unavailable. So the advantages of using cranberry, it is organic, and at the end of the day, you do get the fiber. But whether or not it's truly effective still needs further studies. And just to give some perspectives, what we are looking at in specific in cranberries is the proanthocyanidins. This proanthocyanidins is abbreviated as PACs, and you need more than 30 milligrams of PACs, which is equivalent to 2 liters of cranberry juice. I mean, that just doesn't make any clinical relevance, because you would be actually getting diabetes if you start drinking 2 liters of cranberry juice to prevent urinary tract infection. So before coming to the last parts of the slide, let's just briefly look into another case scenario. A sexually active woman with recurrent urinary tract infection. She wants to explore other non-antibiotic strategies to prevent UTIs. So what do we traditionally recommend? We say advocate hygiene practices, that is for women to wipe front to back. I mean, that is for obvious reasons. And pre and post-coital avoidance of hot tubs, tampon, douching, as well as avoiding tight undergarments, saunas, dirty public pools. These are all traditional recommendations. But what does the guideline actually say? Case control studies demonstrate that these suggestions do not significantly impact on recurrent urinary tract infection. Actually, these approaches can reinforce some amount of shame, self-blame, which are quite common among this group of patients. So the emotional aspect needs to be looked at as well. Patients oftentimes think that these infections are brought upon because they are deemed dirty, which is not the truth here. So if there is one evidence-based behavioral modification that I could impart, that is to drink more water. This is actually a randomized trial published in 2018. If patients are consuming less than 1.5 liters of water per day, by increasing that, they could reduce that amount of infections to about 50%. So let's look at this number a bit more in detail. The efficacies of vaccines are in the range of 25 to 90%. Of course, that's a wide interval. If you're going to take an average, we can park it at 50%. So with the modalities that we have right now, just by drinking more water, we could actually reach the same efficacy of a vaccine. So there's something to think about. So I mean, there's a lot to consider when it comes to a urinary tract infection, and I think the list can just go on. But with the interest of time, let's conclude our talk for today. And the take-home message is this. It is appropriate usage of the tests that are available. We oftentimes dwell into getting a result and treating the investigation, but we do not look into the patient themselves. So this comes in overtreatment and associated financial as well as adverse effects to the patient. So I think with that, I'd like to conclude today's talk. And the take home is fight the temptation, think beyond the urine microscopy. And I thank you for your attention and time.
All right. Thank you, Mr. Ganesh, for the excellent talk. I think we only got one question for you here. What's your opinion regarding honeymoon cystitis and how do we prevent it, Mr. Ganesh?
Thank you. I mean, it's an interesting question, and I think we are talking about awareness, and I see honeymoon cystitis is mentioned. The common misnomer with honeymoon cystitis is oftentimes it's regarded as a female urinary tract infection, but actually the male counterpart can also have this form of infection. That's number one. Number two, on a pure definition basis, it is occurrence of urinary tract infection in a period of abstinence from sexual activity. So that is basically the common denominators in honeymoon cystitis. So, I mean, to start with, these patients were never in the category of recurrent urinary tract infection. So the same measures for recurrent urinary tract infection may not be directly applicable in this group of patients, but the traditional ones, yeah. So I think in this context, hygiene becomes an important aspect, as well as the evidence on water. So drinking, adequately hydrating yourself is also an option. And otherwise, practicing safe sex. So I mean, we only think about when we talk about urinary tract infections, we commonly associate them with E. coli, Klebsiella, Proteus, but we forget to actually address the sexually transmitted diseases as well. So honeymoon cystitis, as sweet as it can be, there's also the sexually transmitted part that needs to be considered. So safe sex and traditional recommendation is the option here. Definitely, there's no role of antibiotics, because unless the patient has any underlying issue and previous history of recurrent urinary tract infection, then that's a different story altogether.
All right, thank you, Mr. Ganesh. Due to limited time frame, we will answer the rest of the questions in the chat box later on. Thank you, Mr. Ganesh.
Welcome. It's nice to have everyone.
All right, we will go to the next and also our last topic on prostate cancer, navigating the path forward. It will be given by our Professor Ong. I think he doesn't need much introduction. He's our consultant urologist in UMMC. We would like to welcome Prof. Ong.
Right, thanks, Desmond. So I have 20 minutes, so we will cover in 20 minutes. Yeah, and I will just thanks everybody, the audience who joined, and also the organizing committee. I do this live one, so I think live one better lah. So this is live. Let me share the screen, and I'm sure you can see a PowerPoint now. Yep. So the title is very broad, prostate cancer, navigating the path forward. But I will just highlight the key point, why the things that are relevant to us today. So acknowledgement, we'd like to thank the organizing committee and also the sponsors and also everyone for turning up. Okay, why do I have to know? Basically, the most important thing is this thing regarding the prostate cancer. The latest official data is this one. That is the National Cancer Registry 2012 to 2016. So that is the latest. Okay. Let me get that. Okay, so that is the incidence. So here there are two registry, 2007 and 2011. So the latest one, 2001 to 2016, is 7.7. Yeah, 7.7 per 100,000. 100,000, 7.7. Yeah, so, and among the male cancer, you have a look here. Yeah, male cancer. Number one, most common is colorectal, followed by trachea, bronchus, and lung, then followed by prostate. So prostate is number 3 in terms of incidence. Number 3 in our country. That is the fact. Okay, so what are the risk factors? I think that's important for us to know. Sometimes also we scratch our head, people, hey, what's the risk factor? Then we have to know lah. There are many one, people, but not many are confirmatory one. I just list three, okay, three important one. There's not a long list like bladder cancer. There is a long list, but this one, just three. Of course, it's age, number one, age. So age is very important one. So the very young people, very hardly they have prostate cancer one. If they're the rare case, if they have, they probably will have some kind of very aggressive kind of tumor. So as the age catch up, then more people in the population who have prostate cancer. So age, and then of course sex. I won't put it here. Like male is a male disease. There will be no, I think no female got prostate cancer. Next one, family history. Family history of all the prostate cancer, roughly 10%. 10% of the prostate cancer, they have some form of family history one. Multiple genes are involved. But of course, nowadays the most famous one will be the BRCA gene. The BRCA gene. BRCA 1 and 2. BRCA 1 and 2. So they give rise to higher risk of breast cancer, ovarian cancer, and so on, right? So that also, that kind of a gene mutation, BRCA gene, will also, lead to higher risk of prostate cancer. Yeah, or BRCA 1 and 2. BRCA 2 is the more, more aggressive one. So that's why some people go, those very well-read patient, very anxious ones. Sometimes they go and do their own genetic testing one, Once they got prostate cancer, they spend a few thousand, go and do this BRCA gene mutation. Some of them do that. Yeah. Next one is ethnic group. Ethnic group. So the ethnic group get more incidence of prostate cancer. That's quite well known. In the literature, of course, the blacks, they have more higher incidence of prostate cancer compared to the white. And of course, white, the Western population have even a higher population than us Asian. So that is the general trend, which is still persistent up to today. Yeah. So that kind of ethnic group variation in incidence. In this one is Malaysia one. Malaysia, of the last few cancer registry, the higher incidence is in the Chinese of all the ethnic group in Malaysia. So Chinese is the one that consistently have a higher incidence compared to the other ethnic group. Now we see, look, compared to the rest of the world, you look at the top of the chart. Top of the chart is the American black, the USA blacks in Detroit. Then Australia, we have 7.7 per 100,000. They have 100 over one. So, per 100,000. So their incidence is 10 times more than us one. So ethnic group, other factors, some say it's dietary, more high calorie, high fat diet, So if any patient asks you, hey, how to prevent all that, So, ethnic group you cannot change, So the, genetic you cannot change also, but the diet you can change, less high calorie, less high fat kind of diet. That will be very helpful. I think that will be very helpful in terms of general health as well, right? I mean, less of cardiovascular disease and all that. So we are somewhere, we are here, below 10, 10 and below one. So we are still good, But you look up there, like Singapore, Korea, Japan, they are like 30 per 100,000 one. So they are more one, as they get more developed, the incidence of prostate cancer increases. Okay. Then this slide is the most important one in terms of the epidemiology, because our country up to now, you see this is the yellow bar is the latest kind of registry. So 53% of the population, when they first come to present with prostate cancer, they are in stage 4 one. They have some form of metastasis. So 52, 53, some population in some area, even 60, 70%. So this is quite, dramatic for, a lot of, doctors overseas when they see, hey, how come your country 50, 60% patient presents with stage 4 disease one? Because in America, that's 5%. That's 5% only people present with stage 4 disease when they first present to the doctor. 95% of them will be early stage. So This one is our own population one. This study published in 2021 is our own population, Malaysian one, and then collected prospectively for 3 years, 2016, 17, 18, up to 2018, 3 years, covering almost, I think, 90% of the government hospital. So this is the survival curve. This is the survival curve. Over years they follow up lah. You see, if stage 1, 2, 3, no problem. Majority of the patients survive. If they die, also they die of other problem, cardiovascular and so on. If they were diagnosed with stage 4, then the survival drop, dramatically. So the median survival, you look at that, that dot there, 50, the 50 point. So about 20 months, 20 months, they survive by, the median survival, 20 months. So this is, quite consistent with the reported literature. So stage 4. So our aim, that's why we have this aim to, whether we should, screen and reduce this, hey, less people come with stage 4 disease, that will be better, right? Yeah. So that is the debate. Now that is the issue here. Yeah. So our role here in the you are the front line, right? Front line in primary care. Our role is to anybody suitable patient for screening, if ever indicated, to help them to get the diagnosis and then refer appropriately lah. So that's the role. That's the main thing. Yeah. Well, treatment, those are fine print. Treatments are fine print. That let the oncologists and urologists worry about that. Yeah. Okay. Now then the core topic today, that is the early detection. So I will let you know the key debate, the key information, so that you will be expert in after the talk today. Okay, your opinion, have that in your mind. Will you recommend screening for prostate cancer? At the moment, still PSA 1. Until now, I think from your medical school or already PSA until now. It's still PSA 1. No other better thing at the moment. Okay, yes, we should screen. B, no, don't. C, don't know, not sure. You have the answer in your mind. Yeah, I will give you the overall picture here. Okay, look at this figure. 162,643. What is this? This is actually a number. Number of patients. Number of patients. 162 subjects. This is a study conducted in Europe. This is a European study on screening. European study. And then this is a known fact for the urology community. Screening for prostate cancer decreases the risk of developing metastatic disease. That is the finding from the European Randomized Control Trial, ERSPC. This was published in 2012, 12 years ago. So they have over 162,000 patients, aged 50 to 69. They have the first paper here, median follow-up, 12 years. 12 years follow-up. Yeah. So relative reduction in metastatic disease, 30% reduction in risk of getting metastatic disease if you screen that. Yeah. So that is the overall survival curve. Yeah. So if you screen them, so they have lower risk of developing metastatic disease, of which we know the prognosis is much poorer compared to 1 to 3. Yeah? Okay, so 12-year follow-up. Then subsequently, they have a 16-year follow-up that was published 2019, right before the COVID pandemic. Yeah, 1 year before COVID pandemic, they published a 16 years follow-up. So it shows this survival curve, cumulative of risk of prostate cancer mortality, cancer specific death. So it also showed that screening, less risk. Okay, so the absolute risk reduction is 1.7 men per thousand. Per thousand. So to avoid one death, you need to screen 570 men. 570, then you avoid one death. So that is the conclusion from this European study. So this is the most well-known one. So if anybody asks you, that the European study is a positive study. So yeah, that is the point. So that's next one. 76774. So that is 76,000, over subject against subject. Another randomized control trial, different. And there are two. Today we are highlighting two. Two of the most famous one, a huge figure. Okay, that is the American one, American trial. Okay, that was another known fact that was published in 2009. Even earlier than the European one, that the American one, in the New England Journal of Medicine. That is, long, 14 years ago. 14 years ago. Yeah. So here they have 76,000 patients, age 55 to 74, follow up 7 years, incidence of death, instead of death, no difference one. This is a negative trial. So if anybody ask about trial or so, European positive trial, the American one was a negative trial. American, surprisingly, everything they want to be better and win one. This one is negative one, negative. Okay, 7 years follow up. So subsequently, in 2017, that was 6 years ago. They have subsequent 15 years old follow up. 15 years follow up of the patient. Prostate cancer and all-cause mortality. So overall survival, which is the same in both groups. You see the intervention arm, compared to the control arm. So the all-cause death, they are the same, 9,000 plus versus 9,000 plus. So negative. So here you see 2017, this publication, after 15 years of follow-up, the two curves just married together. Yeah, so no difference. 15 years. Then the problem, so if anybody asks, hey, what's the problem with this one? The problem is with this trial, this American one, is basically that there is contamination. Contamination. So that's the keyword, contamination. You look at it. Post-screening study, how many of them have PSA done? PSA done. Okay, we look at the intervention group. Okay, 99%, 98.9 have PSA done as part of screening. So we expect 100%, almost capai lah, almost got. But look at the control group. Control group is expect zero lah. Your control, you're not supposed to have PSA done. But 85%, 85 and sometimes 90, almost nearing 90% of them, curi in some way, whatever, like in the healthcare system, whatever, maybe not the fault of the patient, they have a PSA done. So there's heavy contamination of the study, meaning the intervention and the control sama aja lah, they all got PSA done. So that's why that explains why there's no significance in terms of overall survival in the two groups. So this is the key point, contamination of the control group. So here, overall, you see, after 0 to 5 years, 6 to 9 years, 10, 15 years, there are heavy contamination in the control group. So with that, because with all this, the American study showing no benefit. So at one stage, the American government, the one task force say, tak payah lah, no need screening. So with that, so they're trying to be increasing, metastatic disease in US. We say 5%, right? Then the incidence, become higher. So here, the stage 4 become higher. So everybody press the panic button. So after some debate and all that, then come this one. If ever anyone asks about, hey, which is the recommendation people follow? This is the one. Although there are many recommendations, people follow mainly this one. This is the US Preventive Service Task Force. That's the name, quite hard to remember, but this is a US Task Force recommendation. So on screening for prostate cancer, the latest version is this one, 2018, 5 years ago one. So this is the latest task force after they looking at our own American study also got contamination and all that. Now they're taking everything into consideration. So this is the recommendation, but just look at here. I just highlight the key point. 2 key points I highlight. So they now modify a bit. They say 55 to 69. 55 to 69, the decision to screen for prostate cancer should be in an individual one. So you can we discuss with the patient, they want to be screened between this age group, is fine, they have family history, or that they should be screened even earlier. So we decide on that. So it's an informed decision making, kind of a shared decision making. I have to discuss, the pros and cons of screening. Have to be discussed. If patient okay, can accept it, and then we do the PSA test. So it's nothing wrong. Because the previous recommendation by the same task force, tak payah bincang pun, no need to say anything. Tak payah, no need. So now they change. They say can, you discuss with the patient, share decision making, and then maybe you can do it. So that is the latest 2018 US preventive task force recommendation. Latest, this one. So in Malaysia, actually in 2010, that was 13 years ago, there was a publication, prostate cancer screening perspective, the Malaysia one. So all the authors, you see the majority authors are past president or even vice president of the Malaysian Urological Association, led by Datuk Selva. So here they have a screening program. They cover 12 district hospitals, Datuk Selva's initiative. So they cover 2,700 patients, roughly 2,000, almost 3,000 patients. Then they detected 30 prostate cancer. So 1%, 1%. So here's the, I just extract one paragraph from there. So then the politician, they will calculate, because we now go to one state government, they promote for screening. They will say, okay, you got this. How much it costs you to detect one? So by the maths of this, they spend 70,000, the budget there, 70,000, they got 30K. So every case about 2,000, 2,300 ringgit to detect one case. So there is a cost involved there. So we must be aware of that. So the resources, healthcare resources is important. And one more important point. You invite people to come, after PSA got wrong, whatever. Only one half of them come on, They call, the PSA high, come for review biopsy. Half of the men now, they just run away one. So that's a challenge, I think everyone in primary care also aware the male health-seeking behavior is way behind the female. So there's another challenge. So what shall we do? That one is on the left-hand side, is the kind of Instagram snapshot, screenshot from Datuk Seri Nazir Razak. Datuk Seri Nazir Razak himself was diagnosed with prostate cancer. So he's very keen, that everybody should get his screen, and he want to promote awareness of that. So there he said, we must help. That's just 1 month before the pandemic starts. We met him in his house. So then we were beside all the campaign, we also launched the platform for us to learn about how to approach and share decision making for prostate cancer. That's quite useful. This one you can log in there. Here, smart screening for prostate cancer. This developed among the different specialty: primary care physician, public health expert, urologists, oncologists. This was a picture taken when they are drafting the overall course content. So you can see many experts are involved. So it's very good. It would be good if you all can join and ask your friend to join. I think just need an hour only. I think 40 minutes or something to go through that module. So if you have time, I will leave it like 10 seconds here. You just snapshot this QR code. It will lead you to that website if you can. You want to snapshot that, I give 10 seconds to let you snapshot. Then you will go to that Future Learn platform. For completion of the module. That will be great. It's evidence-based. Created, actually, the primary person who created that was a family physician. There's a team from them. Okay, so I will move on. So of course, summary. So of course, screening on all this depend on the local prevalence, mortality, healthcare support. There must be support. So consideration of health economics is also important. So it's a shared decision making at the moment to screen for prostate cancer. That part is a shared decision making. So lastly, I think we have highlighted earlier there is a prostate cancer awareness run. I hope everyone can take the opportunity to come and support. There's another QR code again. I give like 5-10 seconds for you to snapshot. That will lead to the website straight away, for the run website straight away. So with that, I would thank you for your attention. So it is 20 minutes, so I will stop here. Thanks. Back to you, Desmond.
All right. Thank you, Prof. Ong, for this extensive talk on prostate cancer, especially in primary care settings. So I think there is a few questions here. The first question will be, if a 50+ years old gentleman with a PSA of 5.4, ultrasound prostate shows prostate enlargement and calcification within prostate, will this patient could possibly just be benign prostatic hyperplasia, or is there any need to further investigate for prostate cancer?
Yep. All right. Excellent. This is most commonly seen not only facing the primary care physician like all of you here, you also affect us one, come to clinic, see you and see me, see Desmond, or we will be like, oh, you how lah this thing, So very simple one, Okay, statistically, most likely nothing one statistically, but that's statistic, You bet this guy most likely don't have significant cancer. Cancer got two types, one, significant, the angry one, the tiger one that kill the patient. There's also the pussycat one, they live with the patient one. So that is the challenge. So you say 5.5, the PSA. So got two choices one. There are two choices one. Number one is the aggressive one. Aggressive one is that, we must find the cancer one. So then is to refer to a urologist, and the urologist, I tell you, the urology nowadays facility is available. The urologist will do an MRI scan. There's a special MRI, multi-parametric MRI, and based on the MRI, they will advise whether to biopsy or no need to biopsy. So the MRI will give an indication for that. So that is the aggressive approach. So you will write in your case note. I will always write in the case note, so they don't come and blame me at the end. Number two actually is a practical one. Practical approach is that one is actually documented in the module one. That one I show QR code to scan one on prostate cancer screening one. 5.5, you scared prostate big what? Most likely BPH and all. Especially if you've got calcification. If you've got calcification, most of the time it means there's inflammation of the prostate and so on. It doesn't show that it won't suggest got cancer lah. So what you can do is that you can start you assess, do a digital rectal examination and so on, or can start on treatment like in the lecture given earlier. I think there was a lecture covering that, get alpha blocker and so on. Then you follow up the patient via PSA in two months time, even 3 months time, no problem one. As long as the patient follow up and then didn't disappear, then that's not a problem. You can follow up. If it's a BPH after treatment and all that, the PSA normally it will come down one most of the time. So you in your folder you just write give you two options. One, treat as BPH. Will follow up the PSA in 2 months, 3 months, option one. Number two, to refer urologist for further evaluation. You write there in the case note, advise accordingly. I think then it's not a problem already.
All right. So thank you for the explanation. We have the next question. It is, how should we counsel patient before proceed with PSA testing?
That's the important thing. How do we counsel the patient before, say patient asks for, I want PSA testing. I want PSA testing. So how do we counsel? First one, of course, get the history, you got a family history or not for prostate cancer. I think this is the most important fact that we can get. Ethnic group we know already, and then the age we know also. The next important fact is you got family history or not. If they have family history, then you probably err on the side to really suggest for prostate cancer screening. So that's fact number one. Number two, of course, you look at the age range, 55, 69, based on the American recommendation, you could screen for that, but you must tell the patient two things at least. First, you know, if the PSA is raised, you might be referred to a urologist. You might be referred to a urologist. Then they might do an MRI scan, biopsy, and so on. And then number two, that could be false positive or false negative. That could have, you know, psychological impact on patient if they have, you know, thought they have high PSA, anxiety, and all that. And also, if you're negative, also might not mean got no cancer lah. Because I think 15% of the cancer prostate cancer patient have PSA below 4.15. So these are the few factors that you can bring it up with the patient lah. And also, if you refer the urology later, you might need biopsy and so on that I mentioned earlier lah. If they can accept that one, yeah, go ahead and have the PSA taken. So these few points that I mentioned is also in that module one. It's also in the module. They will give you a more systematic approach to screening based on evidence one.
All right. The next question will be on in patient with prostate cancer, which we always saw on prostatomegaly on ultrasound KUB. For those with who were presented with large symptoms, how should we approach that?
Okay. Because nowadays many people can scan. So that's good to have a prostate size measure. Of course, the bigger size doesn't mean got cancer lah. Actually, most of the time, the very big one normally is a BPH one, which is good thing. Which is a good thing. You see what 60 lah, 80 lah, 100 lah. Most of them are BPH, right? Most of them are BPH. So if you see the prostate enlarged or of course the clinical history examination, those are standard. Even though standard must do, yeah. And the next thing you do a PSA test, you do a PSA test to see whether whether it's very high or what. Some also based on the age-based PSA. So the size is not the big issue one. So we still evaluate the normal way history examination and PSA and the urine test, urinalysis. The size actually affect the treatment for the BPH. I think highlighted earlier lah. If current answer is that if the size is more than 40, then the treatment wise is better. Beside the alpha blocker, we add the 5-alpha reductase inhibitor, which is either finasteride or dutasteride lah. If the size is more than 50. And then I think also we must have been highlighted earlier, the normal prostate size, my prostate size not normal one. Desmond prostate size, they're 20 lah maybe, normal 20. My one not normal one, because I think last year I truly go and scan at the MO in radiology told me, Prof, everything okay, abdomen, except your prostate high. Big, or they say my prostate big, lama. I got family history. I think my grandfather got acute urinary retention. Maybe I inherited from him.
Maybe can do the BRCA gene testing, Prof.
Yeah. But don't BPH lah. BPH.
Okay. All right. So I think the next question is, if in a 60 years old gentleman with a PSA of 2, should we repeat when should we repeat the PSA testing? If it is less, if it's normal with less than 4, when should we repeat?
Okay. Yeah. Okay. Of course, the obvious answer is no answer lah. Obvious answer is no answer. But if your PSA is 2 at age 50, you can repeat every year. I personally would repeat every year lah. But some guideline, even in the module, might tell you maybe you repeat after 2 years or so. But within 2 years lah, within 1 to 2 years, repeat one better. Because the best result you can get one at your age 50, you have a baseline. Some people do the baseline PSA, right? If you are 50, I do one PSA now. If it's below 1, then most likely no issue. Most likely no issue. So if this patient PSA is 2, it's not bad yet. He must have a big prostate if you do the scan. If the scan probably show a large prostate. So this patient I think it's better to have if you all well, maybe in 1 year's time, the patient agree. If not 2 years lah. Don't lose them to follow up. I think.
All right. Another question, Prof. At what age is prostate surgery not recommended?
Oh, yeah. This one penting. Again, this one in most Western literature one, they will say the cut-off 70. But that is a very kind of kind of a blunt answer lah, like, you know, the 70 years old one day, then how? Then cannot already. Yesterday you come clinic yesterday, you can have surgery. Tomorrow, today ngam you pass 70, cannot. Very hard lah, this one, but the general guide is 70, because above 70, because why like that? Because above 70, the general condition might have more comorbidity and all that, the general fitness might be less, the, you know, the continence and all that might be poorer lah after surgery. But it doesn't mean that one person above 70 cannot do one. All those with good physical condition, the biological age is probably more important. But the general trend is as a patient get older, for patient with localized disease, if they have high-risk disease, we tend to recommend radiotherapy rather than surgery. But it doesn't mean that the surgery cannot be done.
All right. We'll take the last question. Is that correct that PSA level is influenced by prostatitis sexual activity? And when is the suitable time to do PSA testing?
All right. Thanks. The straightforward answer is yes. So this sexual activity, prostate infection, and instrumentation, even digital rectal examination, it will give rise to a higher PSA. And that one is true. Until today, but this is a scientific thing. It would not be not true after many years. That one is still true one. So I think if such thing happen, you know, you can rest a month, you know, have it done, do again after a month. Not a problem. But scientifically, when will we get done? The half-life of PSA is a very short one. I think, you know, after a week also, we really urgent want to do, also can do. But no hurry, normally no hurry one. If patients are well after 1 month also okay. The half-life of PSA, how many days? How much? Desmond, do you remember? Half-life PSA? Okay, can Google. Okay, you Google half-life of PSA, you will get it one. All right.
Okay, so sorry, I think another last question. I promise you, Prof.
Okay.
There's a very enthusiastic talk, so I think there's a lot of questions coming in. But I promise you, this will be the last one.
Can.
If 70 years old and older and family history of CA prostate, should we do PSA testing? Thank you.
Oh, this one, okay. This one, 70 years old already, you know. The family history of prostate cancer, you know, actually this one, two factor lah. First is, you know, if they have any urinary tract symptom, like BPH1, of course, this is part of the evaluation of BPH1. So you cannot say, oh, you BPH, you said above 70, I don't do PSA for you. I cannot, because part of the evaluation of lower urinary tract symptoms suggestive of BPH1, I think nowadays people do PSA lah. So that's number one. Number two, if very well one, you know, even healthy, nothing one, very healthy one. Then what you do is that you share decision making again, telling the pros and cons of PSA testing. The patient willing say after 70 years old, if a high, I kena pergi line up in the urology clinic, wait for 4 hours. Later mungkin kena MRI, mungkin kena biopsy. The fellow can accept, then go and then have it done. So that's the thing. And then number three, if the patient is very frail, you know, a lot of comorbidity, maybe we err on the side of not doing it.
Okay, all right. Thanks, Prof. Really thank you for this excellent talk and very informative even for us. All right, really appreciate it. So this will be our last topic of the day. We will try to answer all the questions in the chat box later on. And the QR code for these CPD points will be provided later. So I will pass the floor back to Dr. Jeffrey.
Okay, Jeffrey. Thanks, Jeffrey.
Thank you, Prof, for the very interesting and enthusiastic talk. Thank you, Dr. Desmond, for the moderating for these 3 plenaries. All right, and ladies and gentlemen, esteemed speakers, and also our cherished participants, as we draw the curtains on the UMC Urological webinar, I stand before you today. Actually, I'm sitting before you today with a heart full of gratitude throughout this remarkable event. Over the course of our time together, we delve deep into the world of urology, dismantling myth and uncovering truth. I really want to extend my heartfelt appreciation to each speaker who graciously share their insights, experience, and research on every particular topics. To our participants, your active engagement, your thoughtful questions, and thirst for knowledge have been the driving force behind the success of this webinar. I would like to express my gratitude to my organizing team who worked tirelessly behind the scenes to ensure the seamless flow of this event. As we part today, remember that the quest for knowledge never truly ends. So again, thank you for being part of this incredible journey. Stay curious, stay informed, and keep seeking the truth. Until we meet again, take care and be well. And most importantly, the QR code for CPD point will be available after this. Will be in screen for around 30 minutes. Remember to use your MMA apps to scan the QR codes, right? If you are using your phone to stream, please take a screenshot and scan it using your MMA apps. Thank you so much. Okay, thank you everyone.
Thanks, Jeffrey, Desmond. Thanks for the time.
Thank you, Prof. Ong. Very nice talk.
This one, I scan also, or no need? I can scan also, right?
Can scan, can get points.
Scan also, I get some point now. July already, better get point. I scan. Leave it there. I scan now. Not get. Later, Desmond, you might help me get it.
Prof, this one need to scan using this MMA app.
Oh, MMA app. Oh, yeah. No,
Your mics are on, right?
Yeah, I understand. Point, right?
Yes, Prof, 4 points.
I got it. Yeah.